Good morning, good afternoon to my colleagues all around Central Europe. It is a big pleasure and honor for us to welcome you here direct from Vienna. We are transmitting to you a program and a meeting that is very dear and important to us in all Central Europe, but also beyond this area. This is a program that has been organized and is also brought to you by the Central Urologic Society, which comprises all the scientific societies of Central Europe. We work all closely together with a main mission to create a consensus, to advance science, and to improve education for Central Europe and beyond. It is a big honor for me to have two of the big leaders in Central Europe with me, chairing this afternoon through the program. Our main goal was not only to discuss the latest, but also the most controversial topics today with you, and I hope you enjoy it. Important, please do not forget, if you have questions, you can send it to the email that we will blink in a few seconds. We will read them and ask the speaker. Please put them during the talk. And before I forget it, I want to thank the companies that have made this possible through their financial contributions, so we could invite the speakers and also transmit this meeting in the times of Corona. Our platinum sponsor, Astellas, foremost, has been always a big sponsor and helper to us. Our gold partner, Janssen, bronze partners, Richard Wolf, Endoscopy, and Bristol Myers Squibb, BMS, and copper partners BK Medical, Ultrasound Technology of the best, and Medtronic. Thank you very much. Dear Piotr.
Thank you. Dear colleagues and friends, this is a greatest pleasure and very big honor offer you a urological scientific souvenir from Vienna, which is created by Professor Szarak and his team under auspices of Medical University of Vienna and other auspices of Austrian Urological Society. This is the fantastic way to combine the mind from the Central Europe and invite international fantastic faculty for the oncology and non-oncology topic. It's a great pleasure and a very big honor to be together with you, with Professor Szariat and with Professor Minčík from Slovakia.
Okay, hello, dear colleagues, dear friends. My name is Ivan Minčík, and I would like to stress on behalf of Slovak Urological Society to congratulate Professor Szariat for organization this successful scientific meeting. And from my point of view, it's very important to keep in touch in such very difficult time like is COVID epidemic. And I think that everything has been said because it's a very nice program before us, so I will be very short. So you can looking forward for very, very nice lectures.
Thank you so much to my two wonderful co-chairs and our close friends. So unfortunately, as we cannot meet in person in April, we will hopefully in 2022 meet in person. Until then, we wanted to a little bit give you some insights and ideas about things that we are important in urology today. And certainly one of our missions, discussing with my colleagues here and all the other colleagues in the Central Europe that are currently not here, but will give lectures for you, as Peter and Marko Babčuk and so on. It was very important for us that we also cover non-oncology, which is a big part of urology that is often missed. So no further ado, I will introduce the first speaker, Benjamin Pradere. Benjamin is a fantastic, unique person in urology. He's definitely not a rising superstar, but an arrived superstar. He's from France. He's been spent with us now 2 years of his PhD and fellowship, and will stay at the Medical University of Vienna. He's very strong in endoscopy, benign urology, and oncology, so he covers really that broad spectrum. He's published over 150 papers, peer-reviewed, and is well known in many groups and in the YAO group as well as the guidelines. So I'm very happy that he will talk about a problem we often face today more than ever before in our practice, surgery for BPH. How can we preserve ejaculation which seems today to be very important for the patients. Thank you very much, Benjamin.
Thank you very much, Sharak, and thank you to all the scientific committee to giving me the opportunity to present you today this talk regarding BPH. I'm very happy because it's a surgical topic, and sometimes it's very interesting to discuss it with all the mentors. Surgery of benign prostatic hyperplasia is a common problem for saving ejaculation, and during this talk, I will try to kill some old wisdoms that have been spread for now more than 20 years, but are completely changing right now. First, it's important to talk about ejaculation. It's something that we will see we should not miss during our interview with the patients. The dry orgasm that was supposed to be after TURP is not a dogma after BPH surgery anymore in 2021. And the retrograde ejaculation is not the main cause of this kind of dry orgasm, and we're going to see all these 3 points. First, the retrograde ejaculation is unfortunately so far poorly reported. In this meta-analysis of 42 RCT, we showed that there were very few patients who were assessed for retrograde, or I would say anejaculation, and there were very few preoperative evaluation. Moreover, we know that the ejaculation is very important because for 50% of the patient, when they have an orgasmic intensity, when we assess the orgasmic intensity, it's decreased because of the anejaculation. And the ejaculatory function is unfortunately so far the forgotten endpoint in every guidelines. From the AUA to the EAU, we always focus on the same thing to discuss how we're going to treat our patient, the size. But unfortunately, we know now that for patients, the problem is not really the functional outcome. It could also be the erection or the ejaculation. Therefore, since few years, ejaculation is starting to be more and more discussed, and as you see now on PubMed, there is a really increase in this kind of research to really think about what is ejaculation and why we talked about retrograde ejaculation. So please, first thing is that when you see your patient, ask about ejaculatory dysfunction. Up to 30% of the urologists do not discuss ejaculatory complication after the surgery of BPH. And there are tools that are well known to be very representative of the function of ejaculation that should be used as the IPSS score or the IEF for erection. So please start to talk about it when you see your patient. Then we have to explain why retrograde ejaculation, which was so much talked about during the 20 last years, is a nonsense. First, we have to understand the anatomy. The anatomy of the ejaculations come from below, meaning that all the ducts from the ejaculatory ducts came from below the prostate, for the posterior part of the prostate, around the verumontanum with the paracollicular and supracollicular colliculus. So as you see here, we can directly see these ejaculatory duct outlets when we do the surgery, and we have to really follow them when we want to prevent the retrograde or anejaculation. Indeed, the controversy since many years was about the role of the bladder neck. Do we really think that because the bladder neck is opened, the sperm will go directly from the vesicle seminal through the prostate and the bladder? This is a nonsense. And I will explain you why. It came from 1994, and so far no one really checked it anymore. There are some new muscles that have been shown to be involved in the ejaculation part, especially the musculus ejaculatorius. And I will show you this very interesting video which was performed during ejaculation. You see the bladder and the bladder neck on the left part, and on the right part you have the urethra and down to the prostate. And so the patient, you can see slowly that we will have a dilatation of the urethra, and suddenly you have some pulse, which is evacuation on the ejaculation. So it's a live ejaculation with ultrasound. And you see that the bladder neck is still opened. Even the prostate is a bit opened. You see the dark part. But anyway, there is a closure which is really near the prostate and at the time of the verumontanum. Therefore, we know that in this kind of video that there is probably other things that avoid the retrograde ejaculation. So the dry orgasm is not a dogma after BPH. Indeed, when we have this kind of patient who have 80 grams prostate but wants to conserve his ejaculation as before the surgery, now we have a lot of innovation. There is a revolution within the last 10 years with the increase of enucleation and the mini-invasive surgical devices. And many of these techniques have been shown to be effective when we want to prevent an ejaculation. Indeed, the first one with TURP was proposed, and the technique is very simple with a proximal, with an area that you don't touch, which is called the hood sparring, around the verumontanum. And then you try to resect the lateral lobes and the ventral side of the prostate. Indeed, they explain particularly that we have to prevent the resection of the paracollicular tissue, especially because if we go too deep, we will have the injury of the musculus ejaculatorius that I showed just before. Therefore, there is also a randomized clinical trial using this technique with a bladder neck sparring and the hood sparring around the verumontanum, as you can see here. And they were preventing 80% of patients had antegrade ejaculation after surgery, removing everything except around 1 centimeter around the verumontanum. With the laser surgery, it's a bit different. Few studies assessed the risk of anejaculation, or at least the possibility of antegrade ejaculation. In this randomized clinical trial with HOLEP, there were no difference between HOLEP and with specific technique and a normal technique. And with TULEP, which use the same two heels technique, preventing retrograde ejaculation by leaving some lateral lobes around the verumontanum, as you see on these pictures. There were a benefit in the prospective study. Unfortunately, in the randomized study compared to TURP, there were no difference between both groups, TULEP and TURP. Greenlight has a bit better results in the randomized clinical trials in a very small cohort, show antegrade ejaculation in 85% of the patient. And it has been also shown that we can use a technique of preservation of ejaculation with anatomic PVP, if you know the specific technique of vaporization. As you can see here in a intraoperative pictures, you see that there is still the paracollicular and supracollicular part who are preserved. And here it was a video when you see the small part, and after the surgery, you can really see that the verumontanum is preserved and the supra and paracollicular part also. We can also do some new techniques with robot, and especially the simple prostatectomy has been developed the last few years robotically, and we can try to improve antegrade ejaculation using a urethral sparring technique, which has been developed by Wang and recently this month proposed by Porpiglia in European Urology, with 81% of antegrade ejaculation at 1 year. Anyway, there is still some question regarding the cost of these techniques. Anyway, which techniques you use, preservation of ejaculation is feasible with a really good percentage rate. As you can see, for TURP or PVP, you can reach up to 90% of preservation of ejaculation. It's a bit less for HOLEP so far. And the other question is that now we have new mini-invasive surgical device, like Urolift, Aquablation, E-Tint, and Resume, which are firstly proposed for office-based surgery, but it appears that it also helps a lot for preserving antegrade ejaculation. So what are the results for these mini-invasive new surgical devices? Then they are doing quite good, and as you can see here, few studies assessed the MSHQ score, which assess the ejaculation. And for aquablation and urolift, you have similar or improve in terms of ejaculation compared to before the surgery. For Resium and TURP, it was not as good as for aquablation or urolift. Anyway, all this new technique, including arterial embolization of the prostate, improve the potential of antegrade ejaculation. But the other thing that we have to understand is that the surgery is based on a patient. Then the preoperative characters are very important, especially, as I said, the MSHQ score, specialized for ejaculation, but also a cystoscopy could be very interesting before the surgery for preserving ejaculation. As you can see on this picture, this patient has a huge lobe median, and we asked him to have a miction while the fibroscope was in the urethra, and you can see that the median lobe is completely occlusive on the urethra. And this is mainly his first problem. The median lobe is mainly the first problem for his miction. Therefore, you have to understand how your prostate is and then adapt your technique. Of course, incision of the prostate have been proposed many times and are still feasible. When you have a median lobe, as it is shown in this patient, for example, you will see that you can also improve the ejaculation part using just a resection of the median lobe, while you have no median lobe, but you want to, let's see this video, but you want to preserve ejaculation. Can we go directly to the first bladder neck for the Mercedes incision? Yeah, you see here that the bladder neck is very small. There is no median lobe, so the idea is to do an anterior incision, then two other incisions. We can go directly to the second part. Yeah. So first, the anterior incision is made, and we go on lateral sides on the right and on the left. And for small prostate from 30 to 60 grams, it improves definitely the functional outcomes and prevent anejaculation or retrograde ejaculation. This is another video showing that you can do endoscopic enucleation of the prostate with a preservation of the paracollicular and supracollicular part. Anyway, we know that the risk of anejaculation is still higher than in the other techniques. So my take-home message are quite simple today for this talk. I think anejaculation is not systematic for BPH surgery, and you really need to discuss it with your patient. Retrograde ejaculation should be removed from our urological lexicon so far. It's a shared decision-making, and patient information is a key, because we have to inform the patient that there is a risk of failure of 15 to 25%, also a high rate of reintervention in the next 5 years. Precision surgery is as important as medical precision therapy, and we have to assess preoperatively the patient on ejaculation, and you have to adapt your technique to the prostate to treat your patient according to his symptoms, but also his expectation. Does he wants to have ejaculation? Does he needs this ejaculation? And the anatomy of the prostate. Finally, I will just show you this diagram I try to use after information of my patient using evaluation of ejaculation and erection, MSHQ and IEF-15, a preoperative cystoscopy if a prevention of ejaculation is planned to understand the prostate anatomy. Then we finally could decide about the techniques according, of course, to the size of the prostate, because mainly the new mini-invasive surgical devices are indicated in small prostate. Incision of the prostate and partial surgery are feasible, and for a biggest prostate, prostate embolization, endoscopic enucleation, and robotic robotic surgery for simple prostatectomy with urethra sparing can also be performed. Thank you very much for everything.
Thank you very much, Benjamin. There was excellent talk. We really appreciate for this. There is no questions in the audience. We have the question for you based on the technique of the minimally invasive BPH and bladder outlet obstruction surgery. What is, based on your experience, the risk of the bladder neck contracture in a long-term follow-up?
I think so far for the Eurolift, there is no real risk of bladder neck construction because we have to be really beside the bladder neck. For the new ones, we still have not a lot of information. It has been published yesterday, the 5 years results of Resume. And the risk of bladder neck is quite small, especially if you take care to really put your device on the lateral sides and not too close to the bladder neck. But definitely, there is less bladder neck structure than with a standard TURP.
Thank you.
Thank you very much. Thank you very much, Benjamin, for a really fantastic talk. That is, I think, an area that is more and more important, and we've been doing this procedure for a long time. We're talking the wrong taxonomy, the wrong concepts, and I think we're finally entering in an area that's very important. I think the ejaculatory function and the orgasmic dysfunction and all those are major important issues to the patients that we never discuss in detail. So the one question is, I saw, for example, in all this decision-making tree, you certainly are trying to balance this problem versus the efficacy of the intervention. So how do you look at it? For example, prostatic arterial embolization has shown to be inferior in efficacy in some degree. And it's so where do we find the middle ground and how do you discuss it with the patients? And then the second question is, if the problem arises, are there any solutions afterwards?
Yeah, so I would say the first thing, patient information is the key, definitely. We really need to explain them. We have a lot of different tools. And they are adapted to the patient, and we have to adapt them to the patient expectation. This is, I think, definitely the way to change our approach of BPH surgery is not to remove the prostate, but remove the prostate according to what the patient wants. If he's 60 years old with a young new wife and he wants to have erection and ejaculation and he doesn't care to go to the toilets 3 or 4 times during the day, then it's okay, and we have to preserve it. And I think that's the first part. And regarding the complication or the adverse events, especially with the new mini-invasive surgical device, there are some, especially with prostate embolization. We have seen some dramatic necrosis of the bladder or of the prostate. Anyway, so far it's under evaluation. iTind and Eurolift are still under evaluation, and it's still feasible to perform a TURP. The only thing is to explain to the patient that in the next 5 years, a new treatment or medication should be added again to improve the results.
And the question regarding, is there anything we can fix afterwards? The patients come now to us and say, look, my ejaculatory function is, it's a whole, there's no golden solution, right?
No, there is no golden solution to make the ejaculation great again.
Yeah.
No, so far I'm not aware about that.
Okay.
Thank you
very much.
Okay, now it's time to introduce next speaker, next lecture. The next speaker is Professor Zoltán Kopa. He's working in the Urology Department in Budapest. He's also head of Andrology Center in Budapest. So he has a very large activity in field of urology, but namely on andrology, and he will be speak in his pre-recorded lecture about testosterone replacement in the aging man. So please, you can start this lecture.
Dear chairpersons, dear colleagues, it's a great honor for me to be involved in your program, but due to the even stronger circumstances, I'm not able to participate personally, so that's why you will see this lecture pre-recorded. Testosterone replacement in the aging man, that is the title of my talk today, where testosterone with aging declines, with an SHBG increase, a steeper decline in the free testosterone can be seen, while the gonadotropin levels may be increased or inappropriately normal. There is an important contribution of comorbidities, very especially with the obesity. We call this syndrome late-onset hypogonadism. For the diagnosis, we need a low serum testosterone level and the symptoms of the related hypogonadism. As we know, testosterone declines with age after the third decade of the life. And this decline is affected by several factors like genetic factors, adiposity, and some comorbid conditions. There is an increased risk of type 2 diabetes. From the studies, we know that approximately 7 to 14% of middle-aged and older men have low testosterone level when we measure the morning fasting total testosterone. Low testosterone sexual symptoms are not so frequently, especially in younger ages. Between 40 and 50 years of age, the frequency is 0.1%, but it increases to 5.5% in the age category over 70 years. The majority of the patients have low or subnormal LH. This is associated with obesity and other comorbid conditions. When the LH is elevated, this is strongly and mostly associated with age. Let's see a very recent publication from the United States about the testosterone market. Testosterone replacement therapy was approved in the United States in the 1950s for classical hypogonadism. Since the early 2000s, large increase can be seen in the use of testosterone replacement therapies in the United States. Testosterone is on the normal range for young, healthy men without any of the specific well-recognized medical conditions. And there is very interesting from the study that 1 out of 5 patients prescribed with testosterone, the prescription is made without testosterone measurement. The origin of the non-specific symptoms is debatable and questionable. It can be the low testosterone or other coexisting conditions, concomitant medications, and the aging itself. What about the diagnosis of testosterone deficiency? The correct diagnosis is made by ascertainment of symptoms and signs and the measurement of testosterone levels. Total testosterone and free testosterone when indicated, testosterone measurement should be done in the early morning fasting samples on 2 or more days, minimally 2 days. LH and FSH can be measured to distinguish between the primary and secondary form of hypogonadism. Diagnostic inaccuracy can be explained by non-specific symptoms, the overtime variations of testosterone levels, the measurement problems, measurement inaccuracy, the variations in binding protein concentrations, and the suboptimal reference ranges. In a recent publication, Pezin and co-workers presented 7 coordinated placebo-controlled trials with testosterone replacement therapies. What about the effect? Testosterone replacement therapy significantly improves the sexual function, sexual activity, sexual desire, erectile function, the strength and frequency of nocturnal erections, and the ejaculate volume. But this treatment does not improve sexual function in men with normal testosterone levels or men without erectile dysfunction. TRT reduces the whole body and visceral fat mass and increases the skeletal muscle mass, muscle strength, mobility, walking ability, aerobic capacity, and circulating erythrocytes. Testosterone replacement therapy modestly improves depressive syndromes, bone density, and insulin resistance. What about the contraindications? Testosterone replacement should be avoided in case of prostate cancer and breast cancer. Fertility issues are very important. In the case of child wish, testosterone is contraindicated. Another contraindication is the erythrocytosis and the thrombophilia, the severe lower urinary tract symptoms without urological consultation and diagnosis. Recent major adverse cardiovascular events, uncontrolled heart failure, or the severe untreated sleep apnea. There is a question about the risk of testosterone replacement therapy, about the possible complications of this treatment modality. That's why the FDA made a new rule in 2014 about the effectiveness and safety of testosterone, because the effectiveness of the safety of the testosterone replacement has not been established for age-related hypogonadism. This is the question for the age-related problems, for the late-onset hypogonadism. That's why the indication and usage section has been changed. FDA removed the term idiopathic and included a warning about the potential cardiovascular risk with testosterone use. Where significant increase in testosterone use for age-related hypogonadism can be observed, with a lack of definitive evidence of benefit of testosterone replacement treatment in this patient population, and the controversial cardiovascular issue, the controversial data about the cardiovascular risk and complications of testosterone replacement. Some studies suggested potential risk with TRT, and we have also continued publications proving the safety, cardiovascular safety of this treatment. This publication comes from this year, May. Let's see the testosterone trials published after 2014, where these trials assess the effect of testosterone on anemia, bone mineral density, cardiovascular status, cognition, physical function, sexual function, and vitality. The publications reported no improvements with testosterone therapies in these aspects. Results were of uncertain clinical benefits, but there was a low frequency of adverse events, but we have to mention that not designed to definitely address safety questions is a feature of these publications. This systematic review comes also from 2021 for May this year. There is an ongoing study about the safety, cardiovascular safety of testosterone replacement therapy, where testosterone companies started a single trial, which trial is underway now. The estimated completion is next year, June. We're randomizing 6,000 symptomatic hypogonadal men between 45 and 80 years old with an increased risk for cardiovascular disease, where the primary endpoint is a cardiovascular death, myocardial infarction, and stroke. So we are waiting for the results of this study. Approximately not an additional year should we wait for, and so we will have the reliable data about the cardiovascular safety or risk of testosterone replacement therapy in aging men. There is also a very recent publication about the risk of subcutaneously administered testosterone enanthate and the orally administered testosterone anaconate, which are really new products on the market. They have a blood pressure increasing side effect, where the blood pressure is increased in 4 millimeters, mercury millimeters in 24 hours with a sensitive monitoring technique. But this hypertension does not necessarily lead to initiation or changes in the blood pressure medications, but may increase the cardiovascular risk. That's why in these two testosterone preparations, the FDA reported the strongest warning, contraindicated in age-related hypogonadism that are not associated with structural or genetic etiologies. FDA has required the companies that all testosterone products should be examined an ambulatory blood pressure monitoring study with their testosterone drugs. This publication comes also from this year, a very recent one. What about the effect of lifestyle approaches? Exercise is the more potent intervention which can improve testosterone levels, and adding diet-induced weight loss provides a little additional benefit over the exercise. So lifestyle is a very important issue in aging men low testosterone therapy. The LITROS trial was conducted from February 2015 to the end of 2019 in Houston. It was published even in this month as a randomized double-blind placebo-controlled trial with the testosterone replacement and the intensive lifestyle intervention, where the lifestyle was intervened with weight management and exercise training, and cognitive function was examined by this trial. This trial summarizes an improvement in weight loss, insulin sensitivity, reduction of chronic inflammations, subcomponent attention, information processing, memory scores, the delay of neuronal apoptosis, and the acceleration of nerve regeneration. In summary, we can conclude that testosterone replacement therapy decision in aging men depends on low testosterone, where total testosterone, free testosterone should be measured with reliable assays. We should know the potential benefits and risk and calculate with this. Contraindications are the prostate and breast cancer, erythrocytosis, heart failure, and fertility issues. We should consider the burden of symptoms, individual preferences, and the risk tolerance. In summary, we can conclude that the diagnosis and the therapeutic management of late-onset hypogonadism, the management of low testosterone with symptoms of hypogonadism in aging men, is a special decision about starting testosterone replacement therapy remain challenging. Dear ladies and gentlemen, thank you very much for your kind attention. I wish you a good health and send you many greetings from Budapest. Thank you very much.
Okay, thank you very much, Zolta, for very nice, comprehensive lecture. Professor Zsolt Kopa is not connected, so I have only few comments regarding his lecture. I think that to exclude some risk of the testosterone treatment, it should be treatment in intermittent settings, but I am not sure if I am right in this field of area. And my second question could be, but as I said, he is not connected. How often do you measure this PSA level? Because as he mentioned in his lecture, the risk of prostate cancer is quite feasible. It's quite recognizable. So, thank you.
Again here, I wanted to thank you very much for Professor Kopa. I think he at the center, the Semmelweis University, which is one of the leading centers worldwide, not only historically, but also for research and innovation. They've developed really a comprehensive program that is worthwhile visiting. And I think this is a pioneer thought that they had and that is important around the world, that men's health is an area that urology is beyond only surgical techniques and so on. It's also all about men's health and working very closely together with the specialists in other specialties. I think testosterone replacement and the question on cancer, testosterone and cancer is a very interesting one that he has enlightened us about. We have also here a prospective trial where we put patients on testosterone replacement, on those that are hypogonadal, even if they are on active surveillance, similar to Moholy-Kera and so on. And also in the areas of hypoglycemia, on low diabetes, early hemoglobin A1C is elevated, and low depression. Very important areas to discuss, and how testosterone replacement can help there as well in the hypogonadal man. So let's see in the future how we're going to go forward, but this is an area that urology needs to really spend some time and love on. Thank you.
And now, we are honored to introduce the next speaker, which is already known. This is Professor Christian Seitz. He is chairman of the German Urolithiasis Working Group. He is also chairman-elect of the European Urolithiasis Society and the member of the European Guideline Panel on Urolithiasis, great endourologist, the man who knows everything about the stones. Then, urologist, please invest the stones. Chris, the microphone is yours.
Thank you very much. Ladies and gentlemen, welcome. I would like to talk about innovations in urolithiasis. In urolithiasis and in urology, there are traditionally a lot of innovations. So I had to handpick just a handful of innovations which I think will have an impact already or in the near future on urolithiasis diagnostic and treatment. First, artificial intelligence. The use of machine learning algorithms and software or artificial intelligence to mimic human cognition in the analysis, presentation, and comprehension of complex medical data is increasing. Artificial intelligence is the ability of computer algorithms to approximate conclusions based solely on input data. And they can recognize patterns in behavior and create their own logic. To gain useful insights and predictions, machine learning models must be trained using extensive amount of input data, which is a limiting factor. Extensive amounts of input data enable a computer to learn how to perform cognitive tasks with the objective to facilitate medical decision making. On PubMed, we see that publications on artificial intelligence are more than 130,000. If we look at radiology papers, we have 11,000, but still in urology, we have over 3,600 papers dealing with artificial intelligence. And if we break it up to stones, we come to 400 papers. So we can see on the graphics that there is, within the last 5 years, an almost exponential increase in papers dealing with this issue. So far in urolithiasis, artificial intelligence is used to improve stone composition and diagnostic accuracy, to predict outcomes, and to optimize treatment choices for patients. I've just picked 2 papers to explain the current science in this issue. There's a neural network-based algorithm for predicting the stone-free status after SWL treatment. The artificial neural network analysis of this study demonstrated that there is a prediction accuracy of 99% for stone-free rate in the training group, 85% in the validation group, and then 88% in the test group. As a result, treatment modalities predicted as unsuccessful were discontinued. So patients with unfavorable prognosis were transferred to other possible treatment measures, and that would save costs and time. Another radiological study looked at urethral stones in thin slice computed tomography. They looked at 465 clinically acquired abdominal CT scans of patients with suspected renal colic. And the results were that with 100% sensitivity of the system, the false positive rate of 2.7 per CT was still not sufficient. Although you have to consider that there were 19,000 CT slides that were analyzed, so the overall false positive rate was low, but still too high to be implemented completely on its own. So still radiologists are required to go through those images as they have a reported sensitivity and specificity of 95 and 100%. So primary reading of CTs by an automated detection algorithm is not there today, but it will certainly become feasible in the future. The high accuracy rates reported may not accurately capture the heterogeneity of the general population. This is always a problem with studies in a non-heterogeneous population. Nonetheless, these models are likely to play an increasing role in our daily clinical decision-making in the future. And it will allow for a more personalized care in patients with stone disease. Another increasing scientific factor will be proteomics. Proteomics is a word that comes out of proteins and genomes, and proteome is basically the entire proteins of an organism or a cell for a certain time point. Proteomics are introduced into kidney stone research since about 2008. It is a powerful and high throughput technology allowing simultaneous examination of a much larger number of proteins in the biological sample. And it may identify potential modulators of kidney stone formation. Analysis of bacteria isolated from catheterized urine has addressed the pathogenic role of urinary tract infection in kidney stone pathogenesis, and a similar role will also the microbiome have in the future. Proteomics-based characterizations, for example, of the calcium oxalate monohydrate crystal receptors will provide very important information for future drug discovery. So there's a lot of, there are a lot of issues coming with proteomics, which is just in the beginning. So far, we have just a little bit more than 160 publications on urology and stones, but this will, as artificial intelligence, steadily increase. The roles of several surface proteins on apical membrane of renal tubular epithelial cells at the crystal receptors and applied to study alterations in cellular proteome, secretome, and derived from immune cells, the inflammatory response can be addressed in kidney stone disease in the future. There are also data banks that are published, and there's a free access through the internet where you can look at all the modulators that affect crystal, for example, crystal adhesion or aggregation, crystal growth, and crystallization in general. If you look, for example, at nephrocalcin, which has an inhibitory effect on all those modulatory effects, you can look at its action, you can see all the different studies in that field, and with one click you have all the evidence for that special proteome or protein that has an inhibitory effect, for example. So this is a very nice tool if you deal with this in science. Proteomics are incredible challenge to translate these basic research data gained from kidney stone proteomic study to clinical praxis, and successful translation may improve the medical care, especially in early disease diagnosis, but it may also serve as a risk assessment for new or recurrent stones, and of course for preventive strategies. So the research gaps require further elucidations before being able to be translated to the clinic. The combination of proteomics, bioinformatics, functional validation, maybe together with artificial intelligence, machine learning, will narrow down the translational gap between the bench and the clinic. Another more practical aspect, which is in a continuous development, is the miniaturization of instruments. We see in instrument the miniaturization of, for example, percutaneous nephrolithotomy, and we see that our gut feeling that the smaller the instrument is, the smaller the lesion is, the less blood loss or the less complications occur, is probably right. Another miniaturization takes place in our, for example, flexible ureteroscopes. We have now the thinnest ureteroscope, has 7.5 French at its tip. This is now produced by Pusen. And this offers a lot of advantages for our treatment. So with these very small instruments, we have the opportunity to use the same lithotripsy devices we used so far, because the working channel did not change in its diameter. We can use smaller access sheets, so the size of the ureteral access sheet is getting smaller. We may not need ureteral access sheets anymore. We may not need pre-stenting anymore. So this will all serve the patient, the costs will come down, and we will be able to treat patients more individualized. For example, this is a revolution also in the treatment of children for whom at a certain age or below 20 kilogram flexible ureteroscopy was not maybe the right choice, but now with a further miniaturization, this may change. We've seen that the single-use and the reusable instruments are comparable with their properties. We have seen that the instruments, the single-use instruments, have an advantage when it comes to maybe infections or bacterial colonization. However, altogether we can say that a lot of studies have demonstrated that our disposable and reusable uteroscopes are comparable in terms of quality and efficacy. Another new development is in the field of the lasers. We have so far the holmium-YAG laser as our gold standard. Now it is challenged by the thulium fiber laser, which has some advantages in terms of, for example, pulse energy. It has a wider range of pulse energy from 0.025 up to 6 joules. We have a higher frequency compared to the holmium-YAG laser of up to more than 2000 hertz, and also wider range of pulse duration and pulse profile. So these are all aspects that can be used for stone dusting or stone disintegration. The use of the thulium fiber laser in studies so far has demonstrated that the ablation speed is faster, up to 4 times faster and more ablation. There's a higher dust quantity and better dust quality of maximum 250 micrometer diameter. We see that there's a lower repulsion rate. We've seen this also in the holmium laser, for example, with the MOSES technology. But the thulium fiber laser also demonstrates sometimes even an absent retropulsion, and the fiber size can come down to 100 micrometer or 50 micrometer, which further facilitates also flexible ureteroscopy and allows to reach really every aspect within the renal collecting system. Another practical aspects are that the machine is smaller, it is lighter, it uses less energy, and you can use it with a normal faucet. You don't need a special 46 ampere faucet in the OR. There are already some systematic reviews, one demonstrating also that the temperature safety is no issue in the thulium fiber laser compared to the holmium-YAG laser. They conclude that it is a potential game changer for kidney stone disease, but large multicentric prospective clinical studies with a long-term follow-up are still lacking. Another systematic review by Traxair and his group demonstrated that the ideal combinations of laser settings have not yet been established, but it is safe to use in endoscopic lithotripsy and may become the new gold standard. Other aspects are that with the use of this laser, we see also a change of the morphoconstitutional stones, so that might play a role if we analyze the stone dust after the procedure. And last, not least, I want to introduce also the clinical burst wave lithotripsy system, which is a burst wave by ultrasound. In comparison to shockwave lithotripsy, it has a lower energy of about 7 megapascal compared to 40 megapascal peak, and it can really fragment a stone very fast. This is a cystine stone in real time. Here we have a struvite stone in real time. We see it is gone in about 3 to 5 seconds. Hard stones will need maybe 10 minutes. So this is a very effective way to fragment stones. It can also be used to propulse stones within the kidney, so facilitate the expulsion of the stones. Here you can see the stone, it has been moved, and you can see it here also in the ultrasound. The red dot is the stone, and you can move it, it falls down to the ureter, and the stone will be expelled much faster. You can also see stones, and when you treat them, it facilitates and distinguishes the clusters of small stones. You can see that it is fragmented, it doesn't need any more therapy. So there is now also the first study in the clinical in clinical cases in 2 patients, and here we saw that burst wave lithotripsy appeared safe and effective, and it was also tolerated without pain in an awake participant who passed the stone, and additional studies are underway. But we can already see at this time that it might give new indications, for example, for treatments of stones who don't have an indication yet, or for the patient who comes into the emergency department and can be treated while he is basically diagnosed, or maybe in pregnant patients. So we will see what this technology brings. Further studies are underway. So I thank you very much for your audience, and I'm happy to answer any questions.
Thank you very much, Christian, for this really superb talk on the innovations and the latest news. There's been in the last years several controversies on things we thought were important that may not be that important anymore. And could you just enlighten us, what is the latest we know now on medical expulsion strategies? Is that something you use? And the second one, I just philosophically wanted to go through with you through that. Is smaller always better? And in a daily practice, you have new technologies, but is our access, the size of our access, does it matter that much? And where is for you, how do you make your decision making, which approach to use?
Okay, so I think the first answer is that, of course, in the first place, we look for a personal treatment approach. So our medicine today, with all the instrumentarium we have the possibility to have really an individualized treatment. Yeah? So we can offer the patient a variety of treatments. About medical expulsive therapy, yes, I mean there is it's a contradictory evidence, and it is very interesting because I think there's no field in urology that has so many randomized controlled trials as in medical expulsive therapy, and still we are discussing about the evidence and what is the right thing to do. So far, still the guidelines, they advocate the medical expulsive therapy. At the end, you have to discuss this with the patient. You have to tell them that it might work, that it is, but of course, not a secure definitive treatment. So if the patient is willing to try to go for a medical expulsive therapy, a spontaneous expulsion, then I would offer it to the patient as long as he is not severe hydronephrotic, doesn't have fever or infection signs, for example. And he needs to be followed up in a certain amount of time, but I think that helps. And I think all those studies also contributed to the fact that we really try again to give the patient the opportunity to pass the stone spontaneously and not to bring him right away to the OR. The second question is smaller always better? I think less traumatic therapy is usually better, yes. But of course, there are certain cases, very hard, large stones, very complicated systems where also a larger, for example, PNL sheet is still in use, at least in my personal practice and with many other urologists. But we also see new developments with a very small PNL sheets that really treat 4 or 5 centimeter hard stones in a very short time. So this is also in expert hands and a very effective treatment. So we will see what comes. In terms of flexible ureteroscopy, I'm sure the smaller, the better it is, because the imaging, the working channel, that's all the same. So we don't have the light source are even improving. So with a smaller instrument, we really have less trauma and without any compromise we have to make. So I think this is, at the moment, I would say the smaller the better in this case, yes.
And the last question here I had is on education. I mean, you have worked with the OILES and many groups and role on teaching and education as the technologies are becoming more complex and personalized stone treatment or precision stone treatment is also changing. Where do you see that going with simulations? Do you think it's something that we in Central Europe should more invest in? And what is out there that you think could be helpful for easy access and learning?
Yeah, I think education is very important. I think simulation is very important in all aspects of surgery, I think, and especially also in stone surgery. We have, together with ULIS, we have, and with the ESUD, and also with Dominic Veneziano, you know him, we have established teaching courses And I think this is very well appreciated, and we have also demonstrated, evidence demonstrates that the learning curve is flatter and that there's a profit in simulation-based training, of course. In the meantime, we will have probably a new generation of simulation. We will have virtual reality that's on its way, so we have already companies, they work on that also in stone treatment. If that will be beneficial, we will see, but I can hardly imagine that simulation and realistic simulation training will not be beneficial. So I think this will be the future for all fields. Yes.
Thank you very much, Christian. Thank you very much to one of my closest friends.
Thanks.
One of my closest friends and really a master in the art of stone treatment and way beyond of that. So in the same breath, I'm really, really excited to introduce the next speaker, who is not only a master surgeon, recognized all around the world, a scientist of first class, but also a statesman who has advanced the field of urology to really large steps. So Peter Niradi, who is the professor and chairman at the Semmelweis Institute, that is probably the oldest department of urology in Europe, in Budapest, is going to give us a lecture on urethroplasty, a field that needs a lot of exercise, a lot of perfection. There's also a lot of science coming into that field, and I think it's going to be very exciting to hear what his tips and tricks are to not only perform it better, but also to achieve what the patient desires. Thank you very much, Peter, for your next lecture.
Okay. So dear Chairman, ladies and gentlemen, dear friends, so it's really a great honor to share my knowledge about urethroplasty. But first of all, I would like to highlight there is not a perfect urethroplasty. There might be a good urethral surgeon who is able to perform almost all kinds of procedures so that he or she is able to choose always the best procedure for the patient. So according to the guidelines, there is a guideline about urethral surgery as well, and as a definition in males, urethral stricture refers to a narrow segment of the anterior urethra due to a process of fibrosis and cicatrization of the urethral mucosa and surrounding spongious tissue. As you can see, this is highlighted. So the healing depends much rather on the surrounding spongious tissue, which is also called the spongiofibrosis, than the urethral mucosa. These are the symptoms. Unfortunately, even the severe urethral stricture can be symptom-free. Otherwise, these symptoms can be significant and most common occur. So whenever the urine stream is weak, there might be a voiding difficulty, frequency, partial urinary retention, maybe that it can be also a complete urinary retention, recidive urinary infection. So I would like to highlight and I would like to underline that this is very, very important whenever a male has recidive urinary infection, and although he has been undergone all kind of antibiotic treatment, a procedure has to be done, that it has to be excluded there is not a urethral stricture. Bleeding, which is otherwise very is a symptom rather for urinary tumors than urethral stricture. So to perform a perfect urethroplasty, it is very, very important to know whether it is cost effective. So of course, it is not as important from the patient point of view, but it is very, very important from the surgeon point of view. And I would like to show that this is almost the same for the surgeon and also for the patient, and also very similar for the Department of Urology. So although the digital video internal ureterotomy, it is relatively, the procedure itself is low cost, and the complication rate is also not significant if you compare with urethroplasty, which has a higher cost, and the failure rate is much better. So therefore, whenever, although that you perform a higher cost procedure, the failure rate, the success rate is much, much better. These are the diagnostic steps according to the guidelines, so that it suggests to use a validated patient report outcome measure to assess symptom severity, And it is also recommended to perform uroflowmetry and also to do ultrasound to estimate the post-void residual. And the ureterography, which helps a lot for ureteral surgeon, and it has to be performed retrograde to assess stricture location, and also it shows the length of the stricture. And to combine retrograde ureterography, void in situ ureterography to assess pelvic fracture ureteral injuries. So this is the ureterogram, and also in addition, ultrasound can be also used. It can be accessed easily, and it shows, as you can see on the right up photo, that there is a very, very severe spongiofibrosis. So it reflects that this is a really severe ureteral stricture. So in this kind of ultrasound region, that it is recommended to perform really a ureteroplasty. From diagnostic point of view, flexible cystourethroplasty can be also used. It's minimal invasive, and it also helps to characterize the recurrence easier and sooner after the ureteroplasty. How to choose the treatment? How to perform the perfect ureteroplasty? These are the things which can influence your decision: etiology, the length of the stricture, tightness, so what is the caliber, number of, so whether it is a single or a multiple, what is the location, pendular, bulbar, or posterior, degree of the spongiofibrosis, probably this is the most important, and of course previous interventions. These are the options, and a good ureteral surgeon has to choose the best one for his patient. So this is the endoscopic, this is a digital video internal ureterotomy, dilatation, stenting, or open ureteral surgery, and it is recommended to find the appropriate tool for the appropriate object. Despite the fact that relatively recently in surgery and also in urology, the less invasive procedure has been taking place more and more common, there is still a room for maximal invasive surgery, and this is ureteral surgery, so ureteroplasty. But first let's have a look on the internal ureterotomy. It has many advantages. It is easy to perform. It is simple. The recovery is very, very fast. This is a non-leader surgery. The postoperative complications are very, very low. It can be repeated, but how often? And there is an excellent view. There are different modifications, but this is that the simple cord knife is still a gold standard. Laser doesn't bring anything addition. The procedure has to be performed, the cut has to be done in the 12-hour position. Temporary catheter has to be left behind between 3 and 5 days. There is not a guideline which would show us what would be the best. It can be performed in local, spinal, or general anesthesia. In selected patient, repeated ureterotomy or long-term dilatation can be equal, so might be a long-term dilatation might be an alternative in males. Whenever there is a severe morbidity, life expectancy is very much limited, and there were already multiple unsuccessful previous ureteral surgeries. Just to summarize, the complications of internal ureterotomy might be bleeding and infection, but these are very, very mild. These are the risks of recurrence. It has to be taken into consideration because previous ureterotomy decreases the success rate. Whenever anybody has undergone 2 internal ureterotomy, the success rate after the second procedure is 0. So it is not recommended. The pendular membrane stricture, this is of course, whenever the length of the stricture is more than 2 centimeters, whenever there is multiple strictures, untreated perioperative urinary infection, and severe periureteral spongiofibrosis. So this is the list whenever no further internal ureterotomy is recommended. let's go further. Let's have a look on the stenting, which itself looks very, very minimally invasive. But let's have a look from a urethral surgeon point of view. Is it the precise? Is it the perfect uretroplasty? So unfortunately not. This is the answer. This is very, very poor choice for especially a young patient, because after the surgery there is a discomfort feeling. There might be a dribble, post-micturition dribble, and also the volume of ejaculation is decreased. It has very, very severe, or might have very severe side effects, and it needs a complex reconstruction wherever the stent has to be removed. So therefore, this is absolutely not the perfect method. So it can be done in very highly selective cases. I would like to show that whenever I had a special opportunity to visit Professor Chappell, and then we did this procedure together. So it was this stent put in a pedicle part of the urethra, which it hasn't been done. So this is the place where this mustn't perform, and it has to be completed. A full urethra with the spongious tissue has to be removed, and the urethra has to be augmented afterwards. This is one of our own cases in a bulbar stricture. We were fortunately able to completely remove, and thanks for the surgeon who did it, just cut it, and also the half length of the implant was used. We were able to perform an end-to-end anastomosis, and as you can see on the seroflowmetry after the surgery, this patient is able to urinate perfectly. So the outcome is very, very poor. So there is a recommendation: do not use permanent urethral stents, and do not use urethral stents for penile strictures. So I would say this is not the perfect, this is the imperfect kind. So let's go further. Urethral surgery, open urethral surgery, and what is the perfect urethral surgery? What are the tips and tricks? I would generally say there isn't any tip or trick. The tip and trick, as I already started, that a good urethral surgeon is able to perform almost all kinds of urethral procedures, uretroplasty. This is the most important, to find the appropriate procedure, the appropriate operation for the patient. So let's have a look. This is a double skin flap. This is Blendy procedure. This is a procedure which is not used nowadays as frequently as in the past. This is a double skin flap. This is a beautiful operation. It has a relatively good success rate, even in long-term settings. But you can see in the last slide, it doesn't give a perfect reconstruction. It doesn't give a perfect view of or kind of normal-looking penis, because the normal size extra urethral opening is only in the sulcus coronarius, so the glans doesn't look completely normal. In the case of distal stricture, instead of using these skin flaps, nowadays it become very, very popular to use the buccal mucosa graft. The buccal mucosa graft has very, very many advantages, because it's relatively easy to be taken. It is performed by ourselves. It can be done even in local anesthesia, and then whenever it is taken, it can be used as a patch, or it can be used as a tubularized part of it, but I wouldn't recommend to use it tubularized, because its result is not as good. But as you can see in this patient who has already undergone several urethroplasties beforehand, so we were able to perform an almost perfect reconstruction after this procedure. Buccal mucosa graft can be used in multiple settings. So whenever the stricture is longer, as you can see from both cheek, the buccal mucosa graft can be taken and just stitched to each other, and then it has to the skin, the penile skin can be closed over it. The penile fracture, and in the most severe cases, it comes with urethral stricture. It's very, very important to diagnose because in primary management, also the urethral injury has to be operated. Otherwise, as you can see in this patient who was referred after an unofficial or ineffective treatment, so then further and a more invasive reconstruction has to be done, and an end-to-end anastomosis has to be performed to cut the strictured segment of the urethra. Penoscrotal stricture is also a penile skin flap, and it can be used in the penoscrotal part of it. It is also a very nice plastic surgery, but thanks for the buccal mucosa graft, it is easier procedure. It's easier to be taken, and this penile skin flap, even in penoscrotal strictures, it's not as often used as in the past. In the hands of the best urethral surgeon, a preputial island flap can be used. It has a very, very good blood supply, but a long segment, a long flap has to be taken, and even the most proximal strictures, it can be used, and it has a very, very good long-term result. Two-step urethral reconstructions, it's not as sexy because it has to be done in two steps, and before the second step, the penis doesn't look as nice, but it is very, very important in your armamentarium because, especially in Leigh sclerosis, whenever the urethra in its complete segment has to be excised, a buccal mucosa graft has to be taken, and the result is very, very much better whenever the tubularization is performed between 4 and 6 months after the first step, and it is a very good success rate. Two-step urethral reconstruction, again, this is a buccal mucosa graft. You can see on the second and the third photos how it looks like, and then in the fourth one, then it's how it looks like 4 or 6 months after the surgery. And the second step, this nice buccal mucosa graft. This is beautiful, soft and beautiful color. It has to be tubularized. What is the best chance to perform whenever there is a short bulbar stricture? The very best method, even today, is to end resection and anastomosis. End-to-end anastomosis gives the best success rate, which is over 80% in the hands of a good urethral surgeon. In a buccal mucosa graft, whenever the stricture is longer, and especially whenever there is a severe spongiofibrosis, buccal mucosa graft can also help us to solve the problem. In pelvic bone fracture, when membranous prostatic stricture, then the urethra has to be completely mobilized, and depending on how long is the stricture and the spongiofibrosis, there are different methods how you can make the distal stem of the urethra longer. So as you can see here, this is how to perform the two ends of the urethra, and this is how the anastomosis is performed, and it gives very, very good, and it shows a very nice voiding cystourethrogram. In non-traumatic posterior strictures, urethral strictures, or rather it is called a stenosis, there is a posterior urethral stenosis whenever distinguish between whenever the prostate is in situ or the prostate is absent. It is called vesicular anastomosis stenosis. The etiology, it is most commonly due to prostate cancer treatments and 10-year survival, because 10-year survival of prostate cancer is almost 90%. There is a potential for long-term morbidity. So overall incidence of post-urethral obstruction after prostate cancer radiotherapy, it is approximately 5 0.2%. So it is almost even worse than radical prostatectomy. But otherwise, the common causes, as you can see, the radical prostatectomy and energy ablation, it doesn't make any sense whether it is external beam radiotherapy, brachytherapy, cryotherapy, or HIFU. So I hope that I was able to just show you which kind of procedures are available, and your turn is just to find the best, the appropriate procedure to perform the best or the perfect uretroplasty. But just taking into consideration sexual dysfunction or function is also very, very important topic. For instance, in vulvar strictures, whenever I showed you the end-to-end anastomosis, although it has a very good surgical result, the non-transecting procedures, it gives a better sexual outcomes compared with excisional anastomosis. Of course, the decision has to be together with the patient, whether the sexual function or dysfunction is important or the most important. Although posterior uretroplasty, unfortunately, in the injury, highest chance of sexual dysfunction is most of it's attributable to the fracture itself rather than the uretroplasty. So in summary, I hope that I was able to show you what are the advantages and disadvantages of the internal ureterotomy, which is the most common used procedure for to manage urethral strictures, which is safe and reliable operation and successful in simple and short strictures. However, uretroplasty is rather recommended for those who has a complex and longer stricture. And I would like also again highlight that the spongiofibrosis plays the most important role in the healing process. In summary, prenatal strictures relapse is due to spongious ischemia, so this is the poor vascular supply after resection, and spongious tissue scar stimulation during erection. Its recurrence, it is, as I mentioned, it's equal with spongiofibrosis. So there are many procedures. Unfortunately, we are still not able to find the perfect uretroplasty, so there are more questions than answers. And by the end, because of the pandemics, unfortunately, last year in 2020, when we celebrated the establishment of our urological department as the oldest one in Europe, we were not able to meet you, but I hope that we will be able to meet all of you soon, and we will be able to celebrate Central European meeting and also the establishment of the Department of Urology in Semmelweis University. Thank you very much again. Szerintem nem volt, kicsit lehet, hogy hosszabb volt, nem?
Hát 50-kor kezdte professzor úr, és most óra 80. Hát 18. És elmentette most?
Nem tudom, de elmentem.
Nice girl.
They're not sure if they see us. Do you hear us?
Yes, I do, yes.
Hello?
It's a great and brave team, so that...
Thank you so much, Peter. So I think we don't have an image, but at least we can hear you. Peter, first of all, thank you so much for this really wonderful talk. And I have to say, this is an area that takes a lot of finesse, hard work, dedication, passion, and I can't just not think about anybody better than you in this area. The question I had is, and this is a challenge I guess we face in all Europe, in all these highly specialized areas. How much volume and how good do we need to become to do these complex cases as you're doing? I mean, the basics, I see, the guidelines can teach you the general concepts, but it seems to me that, in the regions, to have that expertise and that performance as you have, there needs to be a certain volume of cases you're doing. What do you think about that? Is there any research on this?
I couldn't agree more. So there is a rule in the United Kingdom, so whenever the surgeon is not able to perform minimum 10 cases of a relatively difficult procedures annually, so it means that he or she is not allowed to do it. So, but in our region, so that taking into consideration that, for instance, in Hungary and also our countries. So there are approximately 10 million people who live. It means in the case of injury, so that when it occurs, approximately 1 in 1 million. So it means whenever all of these cases is referred to one center, so there is only one surgeon will be, I wouldn't say perfect, but he will be skilled to perform it. So that it is, I think it has to be centralized. In Hungary, in my country, urethral surgery is allowed to perform, and it is reimbursed only on the 4 medical universities. And it helps a lot, so to centralize these cases. Of course, the team has to be the number of the team has to be relatively limited. And of course, although that it includes in the graduate and postgraduate training, but it is very much appointed, it is very much for appointed surgeons who do. And I think that someone has to perform, let's say, approximately minimum 1 in 1 week, or maximum 2 weeks, and then he or she is gonna become, I would say, a skilled urethral surgeon.
Peter, it was a very, very big pleasure to see you in a great condition and hear to your excellent talk. And we are looking for your extreme activity and creative activity in urology. And we are deeply proud that Semmelweis University Department of Urology is one of the leading centers in Europe in the case of the urethral surgery, very difficult surgery, and with very good results. And please accept all the best from Central Urological Society, from Sharok Shariat and Ivan Binchik and their team, and of course from all the staff from University of Vienna and the Austrian Society of Urology. It's a great pleasure and very, very big honor to be together with you online too.
It was my pleasure, and I'm very much looking forward to the next year. So, and I think it has to be advertised and it has to be organized in advance. And on behalf of the Hungarian Urological Society, I promise that a lot of Hungarian, especially young and promising and also diligent urologists, is going to take part on the next Central European meeting. All the very best. I wish good health and great success. Thank you very much.
Next speaker is University Professor Sasha Aya, who is now chairman of Medical Center in Göttingen, and he is very well known as very, very good surgeon, and he will be speaking about tips and tricks for HoLEP, whole genome enucleation of prostate. So please, can you... This lecture is also recorded, so we will have this lecture on the screen.
Dear Chairman, dear ladies and gentlemen, dear colleagues, it's a great pleasure for me to give a talk about tips and tricks for HoLEP. Some brief facts in advance. HoLEP has come of age in 2016, so HoLEP turned 18 and definitely withstood the test of time. It is in the EAU, AUA and the NICE guidelines mentioned and recommended as the first-line treatment for lung. Dear Chairman, dear ladies and gentlemen, dear colleagues, it's a great pleasure for me to give a talk about tips and tricks for HoLEP. Some brief facts in advance. HoLEP has come of age in 2016, so HoLEP turned 18 and definitely withstood the test of time. It is in the EAU, AUA and the NICE guidelines mentioned and recommended as the first-line treatment for LUTS as a minimal invasive alternative to TRP. Since 23 years we are gathering a large amount of data about HoLEP, and we can say that HoLEP is the most widely scrutinized surgical technique for LUTS and BPH. There are large number, or there is a large number of randomized controlled trials who all come to the same results: HOLEP versus TURP, HOLEP versus open prostatectomy. HOLEP is less invasive and has at least a similar efficacy. In meta-analysis, we could demonstrate that HOLEP is superior in efficacy when compared to TURP. This is due to the fact that HOLEP retrieves more tissue than TURP, leading to a higher grade of disobstruction, even here in this randomized controlled trial proven by urodynamic investigation. BPH is a benign tumor of the transitional zone, and HOLEP means tumor enucleation. HOLEP is an anatomical tumor enucleation. Another intrinsic advantage of HOLEP is that you coagulate, you seal the radial vessels coming from the side once, and this makes the procedure quite easy to perform in terms of vision, and postoperatively you have a maximal tissue ablation under good vision and a maximal PSA decrease. HOLEP can be very fast in experienced hand. The on-block technique is probably the fastest technique, and you reach up resection speeds up to 3 grams per minute. HOLEP definitely will change your practice pattern. Here shown, it leads to a substantial increase of BPH procedures just when you start with. Besides of that, you can use the holmium laser for urethrotomy, lithotripsy, even tumor ablation in, for example, a single kidney. There are different principal techniques we will go through now, so HOLEP is varied and is fun. Let's get started with the principal techniques. This is the 3-lobe technique. You start with a 5 o'clock incision. This is a good way to start HOLEP, to get familiar with the holmium laser. As shown here, you start incising at the bladder neck, then the closer you get to the apical region, the more distance you take to the tissue, because you want to find already the surgical capsule, which is demonstrated here. The surgical capsule is best exposed at the apical region, as demonstrated here by a slight, easy push against the prostatic tissue, and then just letting the laser coagulate and do his work. Then you perform the second incision at 7 o'clock. We use rotating instruments which rotate within the inner shaft, take care of the ureteric orifice. Then you do a retrograde enucleation in between the 2 incisions you have taken of the middle lobe. This is the 2-lobe technique. If you do not have a middle lobe, you can just start this way, that you incise maybe at 5 o'clock or 6 o'clock, it doesn't matter. and then you just skip the middle lobe, which saves you time, specifically if there's no middle lobe. This is a small prostate, and many people say that small prostates are more difficult to enucleate. I always say that every prostate has his or its layer. So also the small prostate, as shown here, have a good defined surgical capsule. You turn the instrument around, you just follow the surgical plane, and sometimes the surgical layer diminishes a little bit towards the bladder neck. So you just cut a little bit more towards the bladder neck. That's normal. But if you see that the tissue gets off the surgical capsule so easily, and you know that you are in the right layer. This is the en bloc technique, the more current technique, at least the way I do it currently or since some years. It's time saving, it's very anatomical. What you can see here is we're starting again apically with the side lobe. Just a gentle push towards the prostatic tissue, towards the side lobe, and just coagulate. Don't cut. This is one of the major messages I want to give to you. Do not cut. Otherwise, it's difficult to find your surgical layer. The holmium laser has a thermomechanical effect. It's a pulse laser. It pushes away your tissue. So here we are going below the side lobe. Then we go under the side lobe. We develop the plane, and we already used this layer now to develop our middle lobe, also in the apical region, which you can see here. Only coagulating, only opening up the tissue. You always work with the entire shaft, which holds you the prostatic tissue away. Here we are at the middle lobe. We cut in front of the veru, and we continue in the same layer towards the right side lobe. Now we start with the right side lobe. We use the same layer. So in this technique, you find your layer once, and then you just use it for the entire prostate. Here we are at the bladder neck. You just release the tissue from the bladder neck, and then you go to the ventral part of the prostate. Since it's so important to find the surgical layer, I demonstrate again how you find it. It's again pericurricularly, the apical tissue. You do not cut, you just give a gentle push against the side lobe and let the laser do its work, let the holmium laser do its work. Just pushes away the prostatic tissue, and the layer will open up. And you continuously coagulate, which you see also by the bleaching of the tissue, as shown here. Bleaching, bleaching, bleaching means coagulation. Very important, besides finding the right layer, is the external sphincter preparation. Here you visualize the external sphincter before you start with HOLEP. And at the end of the enucleation, you cut the mucosa strip, which comes from the urethra. After you have been all around your prostate, you just cut the mucosa strip. This gives you sight on the prostatic tissue, which is demonstrated here. You try to shoot from above to below, away from the sphincter, and you get vision on your prostate more and more, which is shown here. You get around and around and around, and you take off the ventral part, also within the surgical layer of your side lobe. Okay, so external sphincter preparation is very important. Morcellation is the final part of the surgery, which is shown here. I morcellate within the prosthetic cavity, as you see right now. We are within the prosthetic cavity. This helps you that the prosthetic tissue does not escape from your morcellator, and you are less prone to have any accidental injuries. Even with this small little residual tissue, it is possible to coagulation is performed during the whole procedure, as you can see it here. Of course, you will have some bleeding, sometimes from the surgical capsule, as demonstrated here. Then you should take the sufficient distance so that you do not vaporize the vessel itself. When the bleeding diminishes, you feel and see that you have the right distance. Other bleedings, which might be a little bit more profound, are treated the same way. Most importantly is that you have the right distance, that you take distance, otherwise you just vaporize the vessel into the surgical capsule. This is demonstrated shortly in the next video, where you see some bleeding here from the surgical capsule. It's an anterior bleeding close to the bladder neck, and you see that trying to coagulate it, disappears more and more into the surgical capsules. You have to stay calm. You have to, again, to take sufficient distance, but also not too much distance, otherwise you do not get enough energy to the vessel. Here you can see we were able to manage it with the laser. Sometimes it's not possible to laser. This is just blurring, cleaning the prosthetic cavity after HoLEP with the laser, just to have better vision. Here you can see that we use the electrocautery with the loop, because you have a strong arterial bleeding close to the sphincter region, and there is nothing wrong to use the loop just to coagulate. That's what we once in a while do. Here you see the next possible complication. What can happen is capsular perforation, which is no big deal. It does not have any clinical consequence, just you have to correct your surgical layer. You find the surgical layer just there where you normally find it, in the apical region. Don't go again into the capsular perforation, just get a little bit above it and continue your enucleation. There have been studies which could not confirm that capsular perforation leads to more urgency. Here you see that there is some residual tissue in the capsule, in the surgical capsule. This is sometimes easier just to vaporize it than to try to get it out. Then another important aspect is that nowadays we release the entire apical region up to the sphincter very early at the beginning, when we do our side lobe enucleation, as demonstrated here. We enucleate a little bit the side lobe and then go around and around up to the sphincteric region, around and around, so that we have the possibility to have early sphincter release, that we do not have any stretch on the sphincter during the procedure. So the apical side lobe region has been detached, and now we perform the oblique incision of the mucosa, which you already saw during the sphincter preparation. So we are preparing the sphincter already very early, so that we do not have any stretch on the sphincter. anymore. This is demonstrated here and here. So say goodbye to the apical detachment in the sphincteric region. So we take out the catheter on the second day after surgery. Patients are released. They perform urinary flow and residual urine. And my take-home message, just when you look at the image down there, HoLEP is the best. Thank you for your attention. Thank you very much. Hello.
Exciting tour through the transurethral bladder outlet obstruction surgery in case of benign prostatic hyperplasia. We would like to ask you, and please for some comments, Ivan, you have a question.
Yes, I would like to congratulate your results, and as I said, you are very experienced surgeon. You show to us how you are doing enucleation, but what is your recommendation for the problem with, how to say this, not enucleation, but if you are removing the tissue from bladder, morcellation, because there are some problems, you can do it, some injury of bladder. What is your recommendation for this procedure of removing of tissue?
Yes. First of all, thank you very much. I lost the beginning of the presentation, and some parts I didn't really hear from what you said, so be not offended. I'm happy to be here. Now I answer your question. The morcellation is actually not a dangerous part if you take care of some points. One important point is that the bladder has to be filled. And the other point is, which I tried already to stress in my presentation, it's a good way to do it if you take the prostatic tissue into the prostatic cavity. Then also it depends on your morcellator. There's some differences in the morcellator types we have on the market. Yeah, let's say I have some preference concerning the morcellator, but I will not mention it right now. Generally, have the bladder filled and maybe do it in the prostatic cavity. That's very important.
Thank you. Sharuk, please.
Thank you very much. Thank you very much, Sasha. We are very close friends, and you've been in this HoLEP and pushing this technology and experience on forward for quite a long time. First of all, before we even start, I want to congratulate you because Sasha has been just awarded the position of Chairman of Urology at the Medical University of Graz, which is a key position, and it's a big honor and pleasure for all Austria and I think all Central European society to have you now part of our family and be active member, and also to reinvigorate a lot of the areas that the expertise you bring. Thank you very much for that. The second.
Thank you.
So I'm very happy about that. The question I had, our first lecture today was about ejaculation preservation. So are there any techniques or tips that you could give us also with a HoLEP, how we can ensure that, or at least try to ensure that, and what do you discuss with your patients to set their expectations after the surgery?
Yes. I think it was well stressed in the first presentation that you have to tailor your patients. So if you want to preserve ejaculation, if you have a really young patient who's very bothered if he loses this ejaculation, maybe you should think of some current techniques who might more surely preserve ejaculation, as we have Resum, as we have now a new kit on the market, aquablation. I would probably rather go for these techniques if I really want to preserve ejaculation. I personally, I did not do, don't do ejaculation preserving HoLEP because I think it's quite conflicting. As you mentioned yourself, if you leave apical tissue, I think this is the part which leads mostly to some sort of obstruction. And as was also mentioned in the first presentation, you have a higher re-intervention rate. So I rather recommend patients who want ejaculation-sparing surgery to go for another procedure. Although there are people who say, okay, we can preserve the apical tissue and the tissue around the verumontanum, I'm just be honest and I say, okay, if you want to have no problems with micturition anymore, now and forever, go for HoLEP. If your ejaculation is important, maybe consider another technique.
Thank you very much. Sasha, we would like kindly ask you for a comment concerning three things. One is learning curve. The second one, risk of the bladder neck contracture in a long-term follow-up. And the third one, the risk for the urethral stricture in the same way. But also we would like kindly ask you about the limitation of the smallest and the largest volume of the adenoma tissue.
Okay, I'll first address the question concerning urethral stricture or bladder neck stricture or contracture. The risk of bladder neck and urethral stricture is really low. It's not higher, probably a little bit less even in compared to TURP or open prostatectomy. There are enough randomized controlled trials who compared these procedures and they didn't show any significant difference concerning the risk. The risk is around 3%. I'm also a urethral surgeon, so I really, I'm very aware about urethral strictures, and people who get the urethral stricture after HoLEP, they probably really come back to my office, and it's a really rare event. The problem, if a urethral stricture occurs, it's really rather more or less intrasphincteric. This makes it difficult if it occurs, but it's really rare. And the same for bladder neck contracture. Second aspect, learning curve and prostate size. We can put this together. The learning curve, I think the most important thing is that you have a good mentor. This is the problem still, because there are not too many centers who are able to go out and teach, but a good mentor and visiting a center where you see HoLEP is very important. If HoLEP is a routine procedure, as in these centers, you will see that the learning curve does not differ from TURP, but still think about your own learning curve considering TURP. It takes a while, so it takes about 30 to 50 procedures to learn it. And most appropriate to learn it is probably in medium-sized prostates, let's say 40 to 80 gram or 30 to 80 gram at the beginning. The smaller prostates are a little bit more difficult, not in orientation, but to find the layer. But as I mentioned in the video, you find every prostate has its layer. And the very large ones, they are really when you are very experienced, and there is no upper limit concerning the enucleation, but let's say over 300, 350 gram, the morcellation process is just too long. So in the very large ones, I do an enucleation endoscopically and do a mini sectio alta to take out the lobes.
Sasha, thank you very much. We really appreciate for your fantastic talk and very constructive discussion. We wish you all the best, and once again, please accept the congratulations of your new position in Graz University. We are proud of you very, very much. Thank you very much. All the best to you and to your staff. And smoothly, we kindly invite the next speaker. He is a delegate from Serbia. Professor Vladimir Kojovic is a Serbian consultant urologist and pediatric surgeon. He is the successor in the field of the reconstructive medicine and pediatric urology, and also of gender-confirming surgery and genital reconstructive surgery. He is already known as a member of various professional associations, such European Association of Urology, World Professional Association for Transgender Health, European Society for Sexual Medicine, Society for Genitourinary Reconstructive Surgeons, and what is necessity to the big. He is a founder of the Andromedic Academy of Reconstructive Urology in Belgrade. Vladimir, the floor is yours.
Dear friends, dear colleagues, first of all, I would like to thank Professor Shariat and the organizer for giving us an opportunity to present our experience in gender affirmation surgery. So the goals of our lecture are introduction to contemporary transgender terminology. We would like to explain goals of transition process and gender affirming surgery, and to present different surgical techniques of genital gender affirmation surgery. So how do we assign somebody's gender? When the baby is born, we simply look at the baby's genitalia, and according to this appearance, we assign the gender. So it's girl or it's a boy. On the other hand, we have something that is called gender identity. It's individual internal sense of being male, female, or something else. This internal sense is not necessarily visible to the others. So we have phenotype gender, that's appearance of genitalia, chromosomal gender, gonadal gender, and finally we have mental gender, that's gender identity. So what is gender identity disorder? That's incongruence between gender assigned at birth and gender identity. According to international classification of the disease, it is not longer a mental disorder. So transgender, that's individual whose gender identity is different from their gender assigned at birth. Cisgender is the term that we use for non-transgender people. Transition is process. It's psychiatric treatment, hormonal treatment, and gender-affirming surgery in order to align person's anatomy with the identity. Before surgery, according to standards of care, patient need to undergo psychiatric treatment at least 1 year and another year of real life experience in opposite gender. Then it's followed by hormonal treatment under expert supervision, and the psychiatric treatment and hormonal treatment need to be performed for a lifetime. So gender affirmation surgery are surgical procedures that change one's body to match gender identity. So we have top surgery and we have bottom surgery. Top surgery is surgery for the breasts, and bottom surgery is altering the genitalia. Female to male surgery. Its top surgery includes chest reconstruction, chest removal, bilateral mastectomy, and bottom surgery. As you can see, there are many procedures: hysterectomy with salpingo-oophorectomy, meteoidioplasty, phalloplasty, urethroplasty, scrotoplasty, testicular implants, and penile implants. If we go to the opposite direction, then we need to make a breast implant to make breast augmentation, and bottom surgery includes penectomy, orchiectomy, vaginoplasty, and it might include also facial feminization procedures. So in male to female, the biggest question is how to make vagina. We need to make vagina and female with female appearance of genitalia with minimal scarring. And functional requirements includes vagina with enough depth and width for sexual intercourse and with satisfactory lubrication. There are many options for vaginoplasty. Some of them are, used to be performed in the past, like full thickness skin graft, labial skin flaps. But now the method of choice is penile inversion vaginoplasty, and if that fails, we use usually intestinal segments. So this is penile inversion vaginoplasty. It started with total penile disassembly, where we disassemble all entities of a penis. So you can see penile skin, glands with neurovascular bundle, urethra, and the corporal bodies. We remove the corporal bodies completely until its attachment to the bones. We create a clitoris by reducing the glands. We use one piece of urethra for urethral flap. We use vascularized island penile skin flap. We embedded urethral flap into this penile skin flap to enable better lubrication. as in this photo. And finally, we invert this penile skin to create the new vagina. We create a space and finally fix the new vagina. Then we design the labia and the detritus, and on this right photo you can see appearance at the end of the surgery. So the vagina is created, labias are created, clitoris is created and placed in regular position, and we create the female urethral opening. So this is good surgery because it's high success rate and this is less demanding surgery. But on the other side, we can have a short vagina, especially in patients who are circumcised and when there is no enough penile skin. And in this procedure, we can expect poor lubrication of the new vagina. The other option is intestinal segments. You usually use sigmoid colon. We create the sigmoid flap, 8 to 11 centimeters with a satisfactory mucus production. And there are several approaches. We use a stapling device, and finally we create introital flaps for a better aesthetical appearance of the female genitalia. So this is open sigmoid vaginoplasty. You can see the designing of the vascularized flap of sigmoid colon, and the best option is laparoscopic sigmoid vaginoplasty, where this procedure is done by laparoscopic approach. And finally we create introitus, and this is the appearance several months after the surgery. This is good procedure because we can create a very long vagina with satisfactory width, with a good lubrication because of the natural mucus production. Early intercourse is possible, and we have low rate of shrinkage postoperatively. But this is a more complex procedure in comparison to penile inversion vaginoplasty, and there are possibility for severe complications because it is intra-abdominal surgery. Now we will talk a little bit about female to male patients. So in this option, the biggest question is how to make a penis. We have two options. We can use genital tissue, enlarged clitoris, that is surgical procedure that we call metoidioplasty, or we can create new phallus using an extra genital tissue. So this is a phalloplasty procedure. Metoidioplasty is good because we can do it in one stage with minimal scarring, and we can preserve erogenous sensitivity. On the other hand, this is a small penis with penetration is not possible after this procedure. Phalloplasty is good because we can create a large new phallus, and if we put penile implant, we can enable to our patient sexual intercourse with penetration. Unfortunately, this is multi-surgery procedure, so there is a need for several stages, and we can have excessive scarring. So about metoidioplasty, this is a procedure where we use clitoris to become a small penis. This is the designing of flaps at the beginning of the surgery. You can see female genitalia with the clitoris, with labias. We do clitoral lengthening by dissecting the suspensory ligament, as in this photo. We do clitoral straightening by cutting the urethral plate. In that way, we can gain more length, from 4 to 9 centimeters in total. And we start with urethral reconstruction, which is the most demanding procedures. We use vaginal flap. Usually we use anterior vaginal wall and urethral plate to create the most proximal part of the urethra. Then we use buccal mucosa graft, as in this photo. And then we use labia minora flap, vascularized flap, that we join with buccal mucosa graft and create new urethra. So there are several flaps and grafts that we use for this procedure. And finally, we put a testicular implant to finish this procedure. As I said, this new phallus is small, there is no possibility for sexual intercourse, but this patient can void in standing positions. That's the biggest request from them. And they can have, male appearance of their genitalia. If we want possibility for penetrative intercourse, we need to use an extragenital tissue to create neophallus, to have male-like neophallus, to have acceptable scar abdominal side, to enable voiding and sexual function for our patients. Besides trans males, we use this procedure in cis males also after trauma, after penile cancer, like in this photo. Here we can see the patient who had electric current injury with complete loss of penis testicle. Here we have a patient with extraepispadias complex with micropenis, and all these patients are candidate for total phalloplasty. There are many steps in this procedure. The first of all is creation of the neophallus, creation of the urethra, glans contouring, scrotoplasty with insertion of testicular implant, and finally we insert the penile implants. We can use several flaps: radial forearm flap, latissimus dorsi flap, anterolateral thigh flap, or suprapubic flap. So musculus latissimus dorsi is free flap. We use posterolateral back of the patient's non-dominant side. We use thoracodorsal artery and vein, and the superficial femoral artery and the great saphenous vein as recipient vessels. This is how it looks during the surgery. Tubularization of the neophallus while still on its pedicle. You can see how it looks after tubularization. Attachment to the recipient vessels, closure of the donor site, and appearance of the scar several months after surgery. On the other side, we can use radial forearm flap. This is good flap because there is also sensitivity, because we use antebrachial cutaneous nerve to give sensitivity to the neophallus. We connect it to the ilioinguinal and clitoral nerve to enable tactile and erogenous sensitivity. So this is how it looks: designing of a flap, harvesting, tubularization with a tube within a tube, urethral reconstruction, covering of the donor site with free grafts used from patient buttocks, and the final appearance after surgery. And this is the appearance several months after surgery. We can do clitoral glans recontouring, and finally we do penile. We put a penile implant to enable sexual intercourse. So this is very demanding surgery with many complications. So there's a question why we do this surgery. We do it because this is high percentage of these people who attempt suicide if they don't go for a transitional process. Can we really change someone's gender? No, we can just adapt their genitalia to confirm their real gender. Do we need more surgeons, more centers? Do we need more training opportunities? Sure, because there is decades-long waiting list for this surgery. This patient population is very big. In the US, we have 1.4 million. In Austria, it's approximately about 50,000 of people who are transgender. We were lucky because in Serbia, we have Sava Perovic, who performed this surgery many years ago. And we try to establish learning model on live animals. So with our friends, our colleagues from Timisoara, from Pius Branzeu Center, we started a program for training for phalloplasty. Here you can see how we use it on the live pig. We designed latissimus dorsi flap. We harvest the graft with careful dissection of the pedicle, tubularize it while still on its pedicle. Then we detach this phallus from the donor area, and then connect to the recipient area and connect it to the blood vessels in the inguinal region. And finally, we have a pig with a neophallus. We think this is very good and very useful learning tool for a future surgeon who would like to try to do this kind of surgery also on the humans. At the end, I would like to send the warmest regards from Belgrade to our colleagues. All the best.
You are lucky because you had very good teacher. Professor Perovic was famous urologist in this field of surgery, so you are his student. I met you several times and we discussed, if you remember, about these difficulties of this surgery. I have a question, who is paid this very difficult type of surgery in your country? Government or patient has to pay it on your own, or can you explain this policy of this?
Thank you one more time for giving us an opportunity to present our experience in this field, and thank you for organizing this very nice webinar. The question is about the funding, the paying of this gender affirming procedure. So we managed to realize that 66% of cost is covered by the government. So the National Health Service is actually covering 2/3 of this cost for this patient. Some of them who wants to be operated, on the fast line, they can pay that by themselves or by some private insurance. But as I said, government is covering 66% of the surgical costs for these patients, which we think that it is really good because many of them cannot afford this kind of surgery.
Thank you very much. Professor Shariat has a question.
Thank you so much, Vladimir. It's a wonderful talk, and obviously it stems from a lot of expertise and experience. The question I had, you have an infrastructure for that. What else, in addition to the surgical infrastructure and so on, do you need? And can you also tell me, from what age, is there an age cutoff or environmental cutoff that you think it's early on necessary? In these also early intersex are done by different specialists, and who else do you work in your team with to ensure that you have the best outcome beyond the surgery in the psychological part and general health and hormonal, endocrinal, and so on?
Sure, thank you, Sharok. It is a complex issue. So it is truly multidisciplinary field. So you need to be, strongly attached to your colleagues, psychiatrists, first of all, endocrinologists. And actually, we are the last one that patients see, in this transition process. So the surgery is the last step in this gender-affirming surgery. Usually, their transition lasts for many years before they eventually come to us and start to discuss about the surgery. So they are going through very long process of psychiatric treatment, and then when they have a proper diagnosis, then they go for endocrinological treatment, and the surgery is final step. Legal age is 18 when we can do this kind of surgery. They need to have one letter of recommendation from psychiatrist for top surgery, and if you want to perform genital surgery, we need 2 different psychiatrists, who sign that this person has gender identity disorder and genital surgery is recommended for them. If we talk about intersex disorder, it's a bit different. These babies are born with the intersex problem, and it was, it was very, very common to perform early surgery, but now these days we tend to delay this surgery, so the patient can participate in the decision process. So that's very important. So that's the biggest step if we talk about intersex surgery in intersex person.
Thank you very much. And so we kindly ask you for a comment that in the case of transgender patients, male to female, what is the risk of the necrosis of neophallus after phalloplasty? And then what is the material to use to prolong the urethra? And if you use the saphenous graft in that way, or only mucosal graft?
Well, it is a very, very tricky surgery. It's mainly it's microvascular surgery, so you need to perform free flap with microvascular anastomosis. So there is a risk for losing a flap, as in all other type of microvascular surgery with the free flap. It's more, let's say, a plastic surgery, reconstructive surgery than urology. And the urethral reconstruction, it relies on the type of flap that we use. For example, if we use latissimus dorsi flap, if you use flap taken from the back, Then we use, first of all, patient's labia, to create most proximal part of urethra, and in distal part of urethra, we use buccal mucosa graft. So we usually combine these local flaps, labia majora flap, and buccal mucosa graft. If you use a radial forearm flap, then we create urethra immediately using a forearm skin. So we make it tube within a tube and then connect to the native urethra of the patient. So there are different options relying on the actually flap that we will use to create a phallus. It is a tricky procedure. It is a procedure with many possible complications. Complications rates are above 50%. So a proper, counseling with the patient is very, very important. We need to, face them with all possible complications of this challenging surgery.
Okay. I'm pleased to introduce next speaker, who is from Czech Republic. She is working in a very famous hospital in Prague. She is working in Motol Hospital, and her curriculum is full of her activities. She has a diploma of European Board of Examination in Urology. She is also student of PhD. She is interested in experimental surgery, and she will explain for us her strategy for penile rehabilitation after radical prostatectomy.
Dear colleagues, research has shown that 25 to 75% of male experience erectile dysfunction following radical prostatectomy. Therefore, in this lecture, I will talk about preventive and therapeutic strategies for the preservation and recovery of post-radical prostatectomy erectile function. Despite introduction of minimally invasive approaches of radical prostatectomy, particularly the robot-assisted radical prostatectomy, erectile dysfunction is still a common complication following the surgery, and about 70% of males undergoing this procedure experience this problem. The most relevant causal factor of erectile dysfunction is a lesion of neurovascular bundles, which are controlling the complex mechanism of cavernous erectile response, and therefore nerve-sparing approach should be preferred if indicated. What is the underlying pathology is a loss of cavernosal nerve function leading to persistent failure of oxygenation, which leads to loss of smooth muscles due to apoptosis, to collagen accumulation and penile fibrosis, as well as impaired vena occlusive function. All this leads to erectile dysfunction and penile shortening. Penile rehabilitation therapy means the use of medications and devices to preserve erectile tissue health and maximize erectile function recovery. The goal is to improve oxygenation of cavernosal tissue and to prevent endothelial and smooth muscle irreversible fibrotic changes. The treatment options we have include the use of PDE5 inhibitors, the use of alprostadil, or the vacuum therapy. These options could be used singly or in combination, pre-surgery, following catheter removal, during the first month after surgery, at different strengths and dosing frequencies. However, proper algorithm of penile rehabilitation has not been established yet. PDE5 inhibitors represent the most promising treatment options in penile rehabilitation and are widely used in clinical practice. As displayed on the image, it is important to outline that sexual stimulation leading to nerve activation is required to initiate the synthesis of cyclic guanosine monophosphate. Therefore, the response rate to PDE5 inhibitors in non-nerve-sparing radical prostatectomy is very low. Potential benefits of chronicle administration include protection of cavernous tissue against apoptosis and fibrosis, and also improvement of endothelial function and potentially recruitment of endothelial progenitor cells. Several aspects of the administration of PDE5 inhibitors have been investigated, and on the next slide I will mention the most important ones. The crucial questions is if scheduled PDE5 inhibitors are superior to placebo or no treatment. A study by Montorsi comparing vardenafil daily or on-demand use versus placebo showed significantly greater erectile function scores in on-demand vardenafil in comparison to placebo over the entire treatment period. However, the most important outcome of the study was the superiority of on-demand use of vardenafil. I will talk about later on. Another study which has demonstrated the superiority of scheduled PDE5 inhibitors over placebo was a trial by Padmanathan. Sildenafil nightly group was shown to have a higher rate of spontaneous erections, and they postulated that nightly sildenafil increases the chance for return of normal spontaneous erections. Another study by Montorsi, the so-called REACT trial, again, trial on a large number of patients, again, to randomized controlled trial, which was double-blind, double-dummy, and well-designed, was comparing the effect of daily 5 mg tadalafil to tadalafil 20 mg used on demand versus placebo. And this study supports the use of tadalafil once daily, since they proved that it contributes to the recovery of erectile function and also protects penis from structural changes due to decreased oxygenation. According to the recent Cochrane-Vitabai systemic review, what can be summarized is that scheduled PDE5 inhibitors may have little to no effect on self-reported potency at 12 months when compared to placebo or no treatment. Another aspect in the use of PDE5 inhibitors is the comparison between scheduled PDE5 inhibitors to PDE5 inhibitors on demand. The previously mentioned study by Montorsi on vardenafil surprisingly but clearly proved that nightly dosing of vardenafil did not have any effect beyond on-demand use. These results were actually very conflicting and led to a lot of discussion. Another study not showing the superiority of scheduled use was a trial by Pavlovich, which compared sildenafil nightly plus on-demand placebo to on-demand sildenafil and nightly placebo, showing that erectile recovery in 1 year does not differ between the two study groups. In the already mentioned the REACT trial, this has on the other hand proved the superiority and the highest efficacy of tadalafil 5 mg daily compared to on-demand use and placebo. Another study not confirming the superiority of daily dosing of PDE5 inhibitors is the more recent trial by Kim, which compared sildenafil daily to placebo when both patients group were allowed to use sildenafil on demand, and observed that there was no significant difference in erectile function between these two groups. Taken all together, no definitive conclusion on superiority of daily use of PDE5 inhibitors with rehabilitative intent compared to on-demand use can be done. The best timing for PDE5 inhibitors treatment. A study by Briganti showed that 3 years erectile function recovery rate was significantly higher in patients using PDE5 inhibitors versus placebo, no matter on PDE5 treatment schedule. A recent trial by Joe compared the outcomes of patients treated with sildenafil twice a week immediately after surgery to patients who received PDE5 inhibitors 3 months postoperatively. The conclusion was that a significantly higher proportion of full recovery of erectile function occurred in early group. The resume is that early postoperative treatment is of major importance and may lead to better long-term results in terms of either erectile function recovery or erectile dysfunction treatment possibilities. Alprostadil is suitable in patients in whom PDE5 inhibitors are ineffective or after non-nerve sparing prostatectomy. The mechanism of efficacy differs to PDE5 inhibitors as shown on the image. The benefits of administration include suppressive action of transforming growth factor beta and also significant reduction of veno-occlusive dysfunction. However, the best timing for starting the treatment remains unclear. In comparison to PDE5 inhibitors, alprostadil administration is associated with higher rate of adverse events, mainly painful erection, leading to high treatment discontinuation rate. The studies supporting the efficacy of intraureteral alprostadil included trials by Constabile and Reina. Constabile demonstrated higher intercourse rate in patients using MUSE over placebo, and Reina demonstrated that patients using the MUSE therapy achieved in 55% erection sufficient for sexual intercourse. In a prospective study by De la Camera, who was evaluating the effect of topic application of alprostadil, the study showed good recovery of erectile function at 3 and 6 months in patients using Viteros more than twice a week. Another method of administration alprostadil is the intracavernosal application. Penile rehabilitation using intracavernosal injections of alprostadil 3 times per week was evaluated by Montorsi, showing that intracavernosal treatment provided a spontaneous erection in 67%. Gontreo compared the outcomes of intracavernosal injections starting within the first 3 months after surgery to treatment starting 4 to 12 months postoperatively. And he showed that 70% of early intracavernosal treatment group achieved erection sufficient for sexual intercourse compared to only 40% of late treatment group. And he also postulated a reasonable compromise to start intracavernosal treatment in terms of effectiveness and patient compliance at 3 months postoperatively. 5 inhibitors, non-responders, and after non-nerve sparing radical prostatectomy. Optimal timing for the treatment is not clear, and for intracavernosal injection, it should not be earlier than 3 months. Since early start of treatment leads to high discontinuation rate, late treatment is on the other hand associated with less effectiveness. Topic intraureteral application of alprostadil is less invasive method compared to intracavernosal injection and leads to better tolerability. However, the studies are very limited. The evidence for using vacuum erection devices is that upon initiation, oxygen content of blood in cavernosal tissues is reaching 80%, but drops off rapidly after application of constriction ring. Only limited studies regarding the use of vacuum erection devices after radical prostatectomy are available, usually not including constriction ring monitoring and focused on repeated use. In a randomized controlled trial by Vienna, vacuum erection devices therapy was shown to facilitate early sexual intercourse, improve IIEF scores, and preserve patient-reported penile length, and also aided early return of spontaneous erections. In a randomized controlled trial by Keller investigating early vacuum erection devices treatment daily compared to on-demand use starting 6 months postoperatively, he observed that IIEF scores were significantly higher in early treatment group at 3 and 6 months and non-significantly higher at 12 months compared to the delayed treatment group, and as well as no stretch penile length loss was observed in the early treatment group. Vacuum erection devices represent well-tolerated therapy which may minimize penile length loss, and this therapy also provides patients with active way to participate in the rehabilitation after radical prostatectomy with no systematic effects and few local side effects. In conclusion, rehabilitation and treatment are undoubtedly better than leaving the erectile tissue in its unassisted unfavorable fate, which is the idea that doing something is definitely better than doing nothing. The penile rehabilitation should start as early as possibly and certainly prior to penile fibrosis development. Early postoperative treatment may lead to better long-term results in terms of both erectile function recovery and erectile dysfunction treatment possibilities. Data is inadequate to support the use of any specific regime for penile rehabilitation after radical prostatectomy.
Ivan?
Thank you very much for very nice, comprehensive lecture about the treatment of erectile dysfunction after radical prostatectomy. As I mentioned on the beginning of your lecture, you are very active academic young urologist. You are not only active, you are also very attractive, but this is another question. I would like to ask you, you have mentioned everything, but there are still places for patients who are completely non-responders for implanting of prosthesis, inflatable prosthesis for this patient.
Dear Chairman, thank you very much for the possibility to have this presentation. Well, actually, the 15 limit time was a very limited time to go through all the possible options. There are actually even more options that should be worth mentioning is the necessity for the pelvic floor rehabilitation, which also can improve the erectile function. What more can be mentioned is, but again, a sort of a questionable, is the shockwave therapy after radical prostatectomy and its placement. And well, I haven't talked about the implantation of penile prosthesis since I tried to focus the presentation on the possibilities of rehabilitation. And the penile prosthesis, this means already that which is already a viable treatment option for patients experiencing erectile dysfunction, which is unable to be treated with any other medication. So therefore, this is the reason why I haven't talked about this option. Yeah.
Marcela, thank you very much for excellent talk and very fruitful discussion. And now we've smoothly come to the next topic, the last one in that session. Will be provided by Michael Zembrowski. Michał is a young lion of the urology at the Jagiellonian University in Krakow. He is absolvent of the Academy of Physical Activity and the Faculty of Medicine of Jagiellonian University in Krakow. His one topics of interest is penile surgery and treating of Peyronie's disease. Then the topic of the extracorporeal shockwave therapy for Peyronie's disease is absolutely dedicated for him. Mikey, please, we kindly invite you for a lecture.
Good afternoon. My name is Michał Zembrowski. I'm a urologist from Krakow. Thank you for the invitation, and we will talk about extracorporeal shockwave therapy for Peyronie disease. During the initial progressive acute stage of Peyronie disease, therapy should be conservative. However, most concepts of oral and intraregional drug treatment are not effective. No drug is available that can cure all symptoms of Peyronie disease in all patients. However, surgery is only indicated in the stable, non-progressive stage of the disorder. Moreover, not all patients who are candidates for surgical procedure are willing to undergo them. A high number of patients affected by Peyronie disease ask for an alternative treatment, especially after unsuccessful drug therapy. Extracorporeal shockwave therapy has been emphasized as a semi-invasive procedure to fill this therapeutic gap. The use of extracorporeal shockwave therapy for treatment of Peyronie disease was first described by Bellerofonte in 1989. This Italian paper reported a series of 16 patients who had undergone shockwave therapy for penile fibrosis as a result of different causes, such as after priapism, removal of penile implant after casernopography, or in many cases of Peyronie disease. And the result was that it's a safe procedure. After a decade of silence concerning this alternative approach, a large series of 52 patients treated by shockwave therapy was presented by Batz and Teicher at the annual meeting of EAU meeting in 1998. What is the mechanism of action of shockwave treatment in Peyronie disease is still unclear. First of all, shockwave causes direct damage of the penile plaque, and second of all, shockwave treatment increases the vascularity of the targeted area by generating heat, which leads to induction of an inflammatory reaction, resulting in lysis of the plaque and removal by macrophages. The first prospective randomized double-blind clinical trial we have from 2009. It was very good study, 100 patients. Disease duration, presence and severity of painful erection, erection function, quality of life, penile plaque size, and penile curvature degree was assessed at baseline evaluation. The Storz dual shockwave treatment system was used for treatment sessions, which were performed once weekly for 4 weeks. 2,000 impulses were applied at each session, and an emission frequency were 4 Hz. No major complications were observed in patients receiving this treatment, and all patients tolerate the treatment well. None of patients needed analgesic administration during the treatment, and at 12-week follow-up, almost 54% reported pain disappearance and 30% reported pain reduction. Pain remained stable in 4 patients from 50, and that was 9%. A significant difference in erection dysfunction was also reported in shockwave treatment group. Mean plaque size and mean curvature degree, non-statistically significant difference were found. Another prospective study from 2010, in which participated 36 patients, showed that after 6 months, benefits of shockwave treatment for pain in men with Peyronie disease. Also, this study showed that the best outcomes after shockwave treatment were in relatively younger men under 55 years old and with mild penile curvature, 30 degree and less. And the last prospective study from 2011 were Palmieri, the same author of first prospective study in Peyronie disease, investigate the effects of shockwave therapy plus tadalafil 5 milligrams once daily in the management of patients with PD and erectile dysfunction not previously treated. 100 patients, 50 men received shockwave therapy alone for 4 weeks and 50 men shockwave therapy plus tadalafil 5 milligrams once daily for 4 weeks. Pre-treatment data was very well presented with mean degree of the curvature of the penile, which was 21%, After 12 and 24 weeks of follow-up, mean plaque size and mean curvature degree were unchanged. After 24 weeks, intergroup analysis revealed a significantly higher mean international index of erection function score in patients that received shockwave therapy plus tadalafil. These results suggest that the combination of shockwave therapy and tadalafil 5 milligrams once daily may represent a good strategy for the conservative management of selected peyronie disease patients complaining of erectile dysfunction. However, shockwave therapy, neither alone or in combination with tadalafil, was not able to significantly improve plaque size and curvature degree of the penile. Our guidelines say that shockwave therapy cannot yet be recommended as a standard treatment for peyronie disease. It can be used to treat penile pain in the acute phase, and the strength rating is weak. As a take-home message, we should remember that we should not use shockwave treatment for the reduction of penile curvature or plaque size, and we may offer extracorporeal shockwave treatment to improve penile pain. Thank you.
Okay, thank you very much for your very nice and very interesting lecture. May I ask you a question regarding this, the open surgery after extracorporeal treatment? If this treatment was not successful, did you do surgery after this treatment, or is it not possible?
Thank you for the question. It's possible, of course, and the result quite good, but the main thing with this kind of treatment is to inform patient that there can be some complication. I had 2 patients with penile fracture after this kind of treatment, and they received operation. And after shockwave treatment, the operation, is possible, and the results is quite good, but it's a little bit harder to operate in because this tissue is a little bit more sensitive for the cutting and stuff like that.
Okay, thank you very much. No more questions? There's one more.
Thank you very much for the wonderful lecture. And in general, one question I had, in general, this is one of the strategies that could work, and may work to a certain degree in several patients. What is your general, where do you see that in our whole armamentarium of technologies that we have or concepts we have in the management of peyronie's, with even penis string lengthening procedures, or not lengthening, but with devices that are there for that, and in general with other strategies, collagenase and hyaluronidase and so on. Where do you see that in the whole concept? And the other question I had, during the disease process of peyronie's, when is the best to use it, and what age is the earliest age you would start using it, or there's experience on using it?
So to answering for your first question, we have a lot of kind of treatment. That means that no one of this kind of treatment is good for the peyronie disease. And in my opinion and in my experience, this kind of conservative treatment, which we have injection, also extracorporeal wave treatment doesn't work well. First of all, we have to know what is the preference of the patient, what is the strategy we want to have with our patient. And almost always the question of our patient is what we can do with curvature of the pain. They don't worry about pain, they don't worry about plaque size and stuff like that, but only curvature. So as we know, shockwave treatment don't help with in this kind of in this symptom. So I don't use it a lot of with this kind of treatment. And to answer the second question, the best moment for treatment, surgery treatment, is after 12 months, when we know that is the disease is stable, and the age, there is no matter the age. Only if the patient is want to do it, if they have curvature enough to operate. I mean, 40, 60 degree and more, and also dependent on the status of the erectile function. Is this is okay? We can operate with graft, with application, but when the erectile dysfunction exists, we should perform some kind of, for example, AMS 600.
Yeah. Well, thank you very much for this wonderful lecture on an area that is widely used, I have to say, also a lot in the office space and in the private practices. And I think further data will arise on the role from shockwave shockwave therapy for Peyronie's, for erectile dysfunction, and for a lot of fields we're learning more about the technology, but as well as the molecular underpinnings of it. Thank you so much. Thank you very much, and greetings back.
Thank you.
Dear colleagues, so we're going to have a small break of 5 minutes at approximately at 3:50 Central European time. We're going to continue with our oncology section, which is really a superb section with a lot of superbly interesting talks of specialists, but not only on controversies and cognitive important things, but also on techniques and how you could do the surgery better and how you're going to be better in performing the art of medicine and the art of surgery in the individual patient, and very tailored approach. Until then, I want to again thank you for being with us. I want to thank our partners that have been tremendous in supporting us in this activity. That is our platinum partner Astellas, our gold partner Janssen, our bronze partner Richard Wolf and BMS, Bristol Myers Squibb, our copper partner there's BK Medical and Medtronic. Thank you very much for supporting us towards this Central European Urologic Society meeting. And let's meet again in 4 minutes for the oncology part. Thank you very much to my co-moderators as well. Thank you. Welcome back. Thank you very much for participating in this wonderful meeting that is organized by the Central European Society, your society, with the goal, triplicate goal, not only to create consensus in the area, but to advance education and improve science in all Central Europe and beyond. Our goal, this mission of the Central European Society has been created, the mission and the vision, by all the societies in Central Europe. We have come together with the goal of improving all those 3 points in our regions individually on an English platform with continuous medical education options as the one you're experiencing today through this course. So I'm very honored here with the 2 representatives of their society today to take you through this wonderful day where we're going through non-oncological and oncological urology, through all the hard topics, and specifically with the aim of not only discussing the evidence in the literature, but also understanding how the experts deal with the patients and how we can become better in a surgical field and a very practical specialty as urology is. So this second part will be dedicated to oncology, and is no one better to start that section as Piotr Klosta. You all know him, many functions across Europe, in not only across Europe but internationally, as a very recognized master surgeon, a craftsman in surgery, specifically laparoscopic and minimal invasive area, but also a very thoughtful leader who has advanced many areas of urology, and specifically for the Polish society has really taken it to an international level never seen before. So he's one of the founding fathers of the Central European Society, has been a great supporter of that society, has actually received also the first award of that society, of the major contributions to that society. And today he's going to talk about tips and tricks for continence preservation during radical prostatectomy. I'm really excited to hear it because there's an area we all can improve continuously on. Please, Piotr.
Thank you very much. Dear Mr. Chairman, dear Sharok, dear Ivan, dear colleagues from Central European Society of Urology, from Medical University of Vienna and Austrian Association of Urology, this is a great pleasure and a very big honor to be a part of this meeting. This is Krakow, but at this moment I offer you the best wishes from the perfect organized television studio and in Vienna University. Radical prostatectomy is a treatment of choice of localized and locally advanced prostate cancer in the cases who have no contraindications to the surgery and with life expectancy more than 10 years. Since urinary incontinence is the side effect with the greatest impact of patients' quality of life, extensive research on the pathophysiological mechanism related to its appearance has been carried out. The introduction of the laparoscopic surgery in the 90s improved the postoperative evolution of patients undergoing radical prostatectomy. However, the development of robotic prostatectomy has been essential to provide the better functional results after this intervention, due to an improved visualization of the anatomical structures and expand the movement range, certain technical variations can be achieved. Although the exact pathophysiological mechanism involved in the development of urinary incontinence, urinary incontinence after radical prostatectomy still remains unknown. We do know that anatomical and functional changes after prostate are related to organ-confined disease, surgeon experience, and finally, alterations in the bladder sphincter complex and all the pelvic floor structures. The preservations of the bladder neck and neurovascular bundles, you can see it in the down right side of this picture, or the posterior reconstruction of the rhabdosphincter are technical variations which have been described, aiming to achieve higher urinary continence rates in a shorter post-surgical time. There are surgical techniques aimed at the preserving the mechanism of the continence. This includes the continence preservation techniques and reconstruction techniques. If you look at the slide, we can see the bladder rack and neurovascular bundle preservation, apical dissection, puboprostatic ligament preservation, preservation of the membranous urethral length, finally reduced space sparing, and in a construction phase, posterior, anteroposterior, or anterior suspension. The preservation of the bladder neck for the improvement of urinary incontinence, outcomes after radical prostatectomy was proposed after anatomical studies in traumatic patients which demonstrate the importance of the bladder neck in the absence of rhabdosphincter. Please go on to the 230. And if we look for this picture, we can see the careful dissection of the prostate, bladder junction, can maintain most of the circular muscle fibers of the bladder neck, accelerating the return of urinary incontinence. This is the published result of the Polish fraction of the Polish study. This is the first study on the impact of bladder neck preservation on urinary incontinence in Poland. This result shows improved urinary continence rates with a recovery of continence after catheter removal time at 3, 6, 12, and 18 months. Recently, was published a meta-analysis of this technical approach, including one randomized clinical trial conducted in open laparoscopic or robotic radical prostatectomy, finding bladder neck preservation beneficial in the early the 6 months and the long term, more than 12 months, recovery of the urinary incontinence. The bladder neck preservation group had better outcomes for urinary continence after bladder catheter removal at first, third, 6th, and 12 months. However, it is necessity to depict. This meta-analysis includes the studies with diverse definition of urinary incontinence and the small number of comparative randomized studies. Therefore, it is not possible to establish a clear evidence that supports the recommendation of this particular technique in a surgical practice to preserving the continence. Reeves and colleagues observed in their meta-analysis that preservation of the neurovascular bundles favors an improvement in early urinary continence rates, but not in the long term. The authors of this study defined 6 months after surgery as the limit of early continence. 27 studies was included to this analysis. 12 of them were prospective and non-randomized. Patients with preservation of the neurovascular bundles had better results of urinary continence at 6 weeks and finally 3 to 4 months and to 4 months. There is no statistically differences were observed regarding the late urinary incontinence, for example, after 24 months. That due to this deep location of the apex, let's go to the next technique. This is the preservation of the rhabdomyosphincter with the careful apical dissection. This is why the meticulous tissue dissection at this level is essential for early recovery and urinary incontinence, because the prostate meets the sphincter complex and the urethra at the apical level. So the transition between prostate tissue and the sphincter muscle is imperceptible. Then, this is the necessity to depict that when identifying the point where the prostate and sphincter join, the surgeon must keep in mind the anatomical variability of the apex, the horseshoe-shaped external sphincter, and the proximity of the dip of the venous complex. Despite this, there is no any comparative studies available that demonstrate improvement in continence is working in that field. It has been proposed that the role of the puboprostatic ligaments in the preservation of urinary continence resides in the fixation or suspension of the membranous urethra. Stolzenberg conducted a prospective randomized study in patients undergoing laparoscopic prostatectomy with preservation of neurovascular bundles and observed improved early urinary continence rates. This continence rate was observed for 2 weeks and the 3 months in the group of the patients treated with puboprostatic ligaments preservation and compared with the patient without this kind of the surgical tip. This surgical technique does not affect the entire endopelvic fascia, so the preservation of the periurethral support would provide or facilitate the early recovery of the continence. This is the interesting of the preservation of the length of the membranous urethra. Several preoperative magnetic resonance imaging studies, if you look on the right side of the picture, is clearly visible, have been conducted with the aim of the predicting functional outcomes after radical prostatectomy. The length of the membranous urethra is one of the most widely evaluated parameters. A meta-analysis published in 2017 showed higher urinary continence rates at 3, 6, and 12 months after surgery in patients with a longer membranous urethra compared with that group which has present the shorter one. However, several authors postulate that the benefits obtained from longer membranous urethra could be a reflection of better apical dissection. The motor and sensory components of the pelvic nerve have close anatomical relationship with the seminal vesicles. Although this is the incomplete technique, which is also very, very important from the oncological point of view, the preservation of the seminal vesicle avoids nerve damage at the level and provides improved functional outcomes. There are few comparative studies with the small patients cohort. John and Howry obtained urinary continence rate of 60 to 95% at 6 weeks, at 6 months, respectively. In the seminal vesicle preservation group, evaluated with quantitative measurements through the one-path test. Galfano, in another study, described the preservation of anteriorly located structure, a variation that allows avoidance of the retius space structure involved in the continence preservation. And let's look for that study. It's a 2001 Rocco and colleagues described the technique, which is widely used based on the reconstructing of the posterior aspect of the rhabdosphincter based on the previous anatomical studies. The authors postulate that posterior aspect of the prostate with denovilirous fascia, as well as the median raphe with the dorsal part of the rhabdosphincter, constitute an important supporting structure. The posterior or anteroposterior reconstruction are the techniques with most scientific evidence available. If we look at this table, we can see that the trials of Hertz and Menon are only ones with comparable outcomes at 1 month after removal of the catheter, performing the same type of the reconstruction and with the same criteria and same definition for continence. It means 0 pads. From another hand, the Hertz demonstrates statistically significant improved continence rates with this technique. However, Menon and colleagues did not observe any differences between both groups. Sutherland did not evidence that significant improvement regarding quality of urinary incontinence, but the assessment intervals were very, very different. In 2009, Patel and colleagues described the anterior suspension technique, which consists in the placement of the pubo-periurethral stitch after the ligation of the dorsal venous complex, and then through the bone, the periosteum of the pubic bone. They only observed improvement in urinary continence, 90% versus 80% at 3 months in a non-randomized study. Finally, going to the conclusions, a clearly visible situation that there are the numerous technical variations of radical prostatectomy aimed at early recovery of urinary incontinence. The improvement of quality of life is one of the fundamental parts modern prostatic surgery from the oncological way, especially in those patients with the ongoing confined disease and those patients who has the expectation despite in the oncological problem, also expectation to the good quality of life. Still, we have no any consensus on its definition and assessment methodology, which conditions of the evaluations on the scientific evidence about urinary continence is more the proper way. The reconstruction of rhabdosphincter is based on the statistical relations, only one technique that appears to improve early urinary incontinence. But the oncological point of view is fundamental in that way. If you look at this slide coming from 2009, we can see that the comparison different technique, infra and interfascial, may improve the functional outcome, especially in infrafascial technique, but can be associated with the worsened oncological outcomes. Then, while surgeon is learning a new technique, numerous patients may achieve the outcomes inferior to what they might otherwise have obtained with an experienced surgeon. The current data suggests that results ultimately depend more on surgical technique than on surgical approach, and surgeon experience and the organ-confined disease and proper understanding the anatomy of the prostate are at this moment fundamental part of preserving continence after radical prostatectomy done because oncological way. Thank you very much.
Okay, thank you very much, Peter. Excellent, fantastic overview of this very important topic, because the quality of life after radical prostatectomy in terms of continence is very important. You have mentioned 8 types how to preserve continence. On the first place you put bladder neck preservation. May I ask you if it's not possible, I mean that you have a big middle lobe, what is your next step?
It's a very good question. Bladder neck preservation is possible, especially in those patients who has a no large prostate and no middle lobe expanding to enter of the bladder neck. Of course, the preserving of the bladder neck is not possible at that way. It's clearly go to bladder neck reconstruction. It can be posterior reconstruction of anterior reconstruction. In the previous century, also postulated techniques as maneuvers improve well result of the urinary incontinence. But in the case of the large prostate and the middle lobe, there is the only way to tightly suturing urethra with the bladder neck as anterior and posterior reconstruction.
Okay, thank you.
Thank you very much, Piotr, for this really superb talk. I had 2 questions. One is, in your general approach to, let's say, what Ivan has talked about, let's say, advanced cancers, you know, patients T3B or bladder neck invasion and so on, do you have a different approach, or salvage prostatectomies in select young people? Do you have a special approach for the continence preservation? And the second one is there perioperative period or before surgery any strategies that you choose, like prehabilitation with a sphincter training before, a Kegels afterwards? You have a sort of a program. And if the third question is, from what moment on do you counsel the patient to have some additional intervention for incontinence? Is there like a time span you say after that time we're not going to see any improvement?
Thank you, Sharon, for the questions. I think that they are the fundamental for finalizing the conclusions of the talk. Answering on the first one, oncology is the first. It's a radical prostatectomy, both in a advanced, locally advanced disease, both in an oligous metastatic disease, both in a high oncological potential disease. First one is an oncological surgery which must cure the patient. And of course, we cannot forget that the surgery may be consist with the worst functional result for the patients, but I think that maximal eradication of the disease influence for the long-term results and the life of the patients. The rehabilitation of muscle, of pelvic floor muscle, is one of the fundamental part of the modern medicine and modern functional urology. In our patients, we recommend the muscle training as in at least in 1 month before surgery, based on the contractile sphincter, and increase the physical activity. Although the majority of the patients are operated via laparoscopic or robotic assisted way, then physical activity is much convenient for them and much offered much benefit in a postoperative period comparable in those group who not accept these physical activities. Every physical activity in this way is gone under auspice of specialized staff in this matter.
Fantastic. Thank you so much.
Thank you very much.
Thank you so much.
I am pleased to introduce next oncological lecture, which has been done by Professor Jasmin Bektic, who is working in university in Innsbruck. Innsbruck is my second favorite city in Austria, of course, after Vienna. And he will be speaking about metastatic hormone-sensitive prostate cancer. It will be state-of-the-art lecture. So, Jasmin, please, you can start your pre-recorded lecture, and then we will have some questions for you.
Ladies and gentlemen, dear colleagues, my name is Jasmin Bektic, and I'm urologist at the Medical University of Innsbruck. It is my great honor to be a part of this meeting, and I want to thank Professor Shariat for the invitation. I will talk today about metastatic hormone-sensitive prostate cancer, state of the art. You can see here the landscape of prostate cancer. And patients with metastatic hormone-sensitive prostate cancer can be presented, the first diagnosis, as metastasized, so-called de novo metastatic hormone-sensitive prostate cancer. Or are the patients with primary progressive metastatic hormone-sensitive prostate cancer, that means they had treatment of prostate cancer in not metastatic disease and showed recurrence or progression after the primary treatment. The management of metastatic hormone-sensitive prostate cancer changed a lot in the last years. For many years, androgen deprivation therapy alone as a monotherapy was standard of care. Beginning with 2014, with the first presentation of Chartered trial, there was a very rapidly evolving standard of care for men with metastatic hormone-sensitive prostate cancer due to the results of randomized prospective trials like Charted and Stampede, like Latitude, Titan, Arches, and Ensamet. So the treatment landscape of advanced prostate cancer changed a lot. And for the patients with metastatic hormone-sensitive prostate cancer, we have now the possibility to use different combinations therapy of ADT plus abiraterone, apalutamide, docetaxel, enzalutamide, or radiotherapy. And this is already showed in the guidelines. Here, the guidelines of European Urological Association. So we should offer ADT combined with chemotherapy, docetaxel, with abiraterone acetate plus prednisolone, or apalutamide, or enzalutamide, or with local prostate radiotherapy in patients with low volume de novo metastatic hormone-sensitive prostate cancer. So can we define the standard therapy for first-line metastatic hormone-sensitive prostate cancer? What should we know to choose the therapy or to have the therapy options for our patients? We have to know, does the patient has previous treatment? Yes or no? And what is with metastatic burden? Is it a low or high? Here you can see all different situations by metastatic hormone-sensitive prostate cancer, with or without previous local treatment, with metastatic burden, low and high, and with possible therapy options, ADT or ADT as a combination with abiraterone, prednisolone, apalutamide, enzalutamide, docetaxel, or radiotherapy. If we have a patient with metastatic hormone-sensitive prostate cancer with previous local treatment and low metastatic burden, we can combine the ADT with apalutamide due to the results of Titan study, or with enzalutamide due to the results of Arches and Ensamet study. If the patients with metastatic hormone-sensitive prostate cancer had previous local treatment and high metastatic burden, in this case we can again combine ADT with apalutamide or enzalutamide, or with docetaxel due to the results of Charted trial. If we have a de novo patient, so without previous treatment, with low metastatic burden, in this case we can combine ADT again with apalutamide or enzalutamide, or we can use local radiotherapy of the prostate due to the results of Stampede trial arm H. And if we have de novo patient, but with high metastatic burden, in this case, we can combine ADT with abiraterone acetate and prednisolone due to the results of Latitude trial, with apalutamide, or with enzalutamide, or with docetaxel. So you can see here again all different situations of metastatic hormone-sensitive prostate cancer and possible therapy options. And for apalutamide and enzalutamide, both of them can be used in all different situations with or without previous local treatment, with low or high metastatic burden. Due to the results of the studies, because they used all-comer population, patient population in these trials. Here's a slide presented by Horvath Lisa at ASCO this year, showing the results of the publication of Gillesen, published in European Urology 2020, results of APCCC meeting. As you can see, the most people would treat patients with high volume disease with ADT plus docetaxel or ADT plus androgen receptor signaling inhibitors, abiraterone, enzalutamide, or apalutamide. And patients with low volume metastatic hormone sensitive prostate cancer could be treated with ADT plus radiotherapy to the primary tumor if the patient is de novo, or plus systemic treatment, preferably androgen receptor signaling inhibitors. These are the voting results of APCCC meeting. At the time point of the publication, no additive benefit from docetaxel plus ADT plus androgen receptor signaling inhibitors was observed, not yet. What we know is that we have better results using combination treatment. So we should not offer androgen deprivation monotherapy to our patients, with the exception if they have contraindication for combination therapy or if they are not willing to accept the increased risk of side effects. But in any case, in metastatic hormone-sensitive prostate cancer, ADT monotherapy is not anymore standard of care, but combination therapy. Again, to the landscape of prostate cancer with de novo metastatic hormone-sensitive prostate cancer and primary progressive metastatic hormone-sensitive prostate cancer. De novo metastatic prostate cancer is less common, with 6 to 8%, compared to primary progressive metastatic hormone-sensitive prostate cancer with 9 to 18%. And this is a good because M1 at the initial diagnosis is a negative prognostic factor. As you can see on this slide, patients with de novo disease have higher percent of Gleason score 8 to 10 prostate cancer, 66.5% versus 44.6%. And the shorter median time from diagnosis to castration resistance. You can see again 2.4 years for de novo disease compared to 6.2 years for primary progressive metastatic hormone-sensitive prostate cancer. And the prognosis of de novo metastatic prostate cancer is poor. As you can see here, overall survival for de novo patients is much shorter comparing to primary progressive disease, 6.2 years versus 11.6 years. So is there implication for earlier and more aggressive treatment for men presenting with de novo metastatic prostate cancer? At ASCO this year, Fizazi presented his first results of PEACE-1 trial, which focused on the patients with de novo metastatic hormone-sensitive prostate cancer. This is a phase 3 trial comparing standard of care with standard of care plus abiraterone and or local therapy in men with de novo metastatic castration-sensitive prostate cancer. Here you can see the design of PEACE-1 study. As I already mentioned it, they included only de novo metastatic castration-sensitive prostate cancer patients. The patients had distant metastatic disease by at least one lesion on bone scan and or CT, and they stratified patient by ECOG performance status, metastatic sites, type of castration, and docetaxel use, yes or no. They included 1,173 patients in this study and presented by ASCO this year the first results of standard of care versus standard of care plus abiraterone. And the definition of standard of care changed over the time. As you can see here, the standard of care from 2013 to 2015 was ADT monotherapy. From 2015 to 2017, docetaxel was permitted as a part of standard of care, and from 2017, docetaxel was mandatory as a part of standard of care. The co-primary endpoints were radiographic progression-free survival and overall survival. They presented this time only radiographic progression-free survival. The overall survival data is still immature. And secondary castration-resistant-free survival, prostate cancer-specific survival, PSA response rate, and toxicity, quality of life, and so on. Here you can see the patient characteristic of PEACE-1 trial. As you can see, they included patients with low and high disease burden. More patients had high volume disease. And 60% of patients had triple therapy with ADT and docetaxel and abiraterone or without abiraterone. The follow-up and duration of treatment for ADT plus docetaxel population was 36 months. Here you can see the results of radiographic progression-free survival. Here, for overall population, that means standard of care was ADT with or without docetaxel. And as you can see, the results were much better for the patients with a combination with abiraterone and standard of care, with hazard ratio of 0.45 and median radiographic progression-free survival for 4.5 years versus 2.2 years for standard of care group. And looking on the docetaxel population, so standard of care was ADT plus docetaxel. Again, much better results for group with standard of care plus abiraterone, 0.5 hazard ratio, 4.5 median radiographic progression-free survival versus 2 years median radiographic progression-free survival for standard of care. So that means 2.5 years better radiographic progression-free survival for the combination with abiraterone. This is a subgroup analysis of radiographic progression-free survival. So you can see here abiraterone effect in different subgroups. And as you can see, radiotherapy, yes or no, docetaxel, yes or no, low or high metastatic burden, high or lower Gleason score. In any case, the results were better for the combination of standard of care plus abiraterone. Castration-resistant prostate cancer-free survival was one of the secondary endpoints. And you can see here the results for overall population and docetaxel population. In both cases, much better results using combination of standard of care plus abiraterone. And clinical progression-free survival as an exploratory endpoint. Again, overall population on the left side, docetaxel population on the right side, and better results for the combination with abiraterone with hazard ratio of 0.5 in the docetaxel population. The toxicity, what is with the toxicity in the case of triple therapy? Is there much more toxicity using the triple therapy? No, the results have not shown much different grade 3 to 5 toxicity in these patients. And interestingly, gastrointestinal toxicity and fatigue was even less common in the combination group with abiraterone, and Fizazi suggested that this could be effect of prednisolone used in the case of abiraterone. So the triple therapy with prednisolone with ADT and docetaxel significantly improved radiographic progression-free survival, approximately 2.5 years. And no meaningful additional short-term toxicity was observed. So, do we have a new standard of care? Should we wait for overall survival data, or should we already now say this is a new standard of care, at least for the patients with de novo metastatic hormone-sensitive prostate cancer? Let's look at on the results of other studies. And the most similar study with a PEACE-1 study was ENSAMED study. So they also included patients treated with docetaxel. There was about 45% of patients with triple therapy, enzalutamide, ADT, and docetaxel. As you can see on the graphs, on the left side, PEACE-1, on the right one, ENSAMED, for clinical progression-free survival, the results are similar. But in the ENSAMED study, the triple therapy improved radiographic progression-free survival, but there was no change in overall survival. So in the PEACE-1 trial, abiraterone or triple therapy with docetaxel and ADT improved radiographic progression-free survival by 2.5 years, but we have to await results of the overall survival to see what's happened. So we know that the combination therapy, is better than androgen deprivation therapy alone. We know which patient can get which combination therapy due to the results of randomized prospective trials. But what we need are biomarker diagnosis to give the patients the best possible treatment. And we have to know our patient because we don't treat disease, we are treating the patients. And we know for our patients that the combination therapy in metastatic hormone-sensitive prostate cancer is much better than ADT monotherapy. But what is it with the real-world treatment? Here the results of a study in a community oncology setting in USA. And as you can see, ADT monotherapy or ADT in the combination with anti-androgens is still very common use. Even in 2019, over half of patients with metastatic castration-sensitive prostate cancer treated in real world did not receive first-line treatment intensification. And also in US health insurance database, again, over a half of patients that have ADT monotherapy, which was shown that is inferior compared to ADT combined treatment. So it seems that the reality is very complex, and equal valid observations from different perspectives can appear to be contradictory. I hope that results of using or data of using combination therapy in Europe are much better. And I want to thank you again for the invitation to be a part of this meeting. And I want to thank for your attention. I wish you a nice meeting, a nice day, and greetings from Innsbruck. Thank you very much.
Thank you very much, Jasmine. There is no doubt that your state-of-the-art lecture has absolutely highest level. You put on your lecture a lot of evidence-based data regarding to treatment metastatic hormone-sensitive prostate cancer, so discussion could be very long, but I have only two or three short questions. How is the situation in Austria regarding to metastatic hormone-sensitive prostate cancer? In our country, we have about 15% patients with de novo metastatic hormone-sensitive prostate cancer. And what is your recommendation if patient has metastatic hormone-sensitive prostate cancer with low volume but with high grade, Gleason high grade score more than 8. Can you answer these two questions?
I hope you can hear me. You can hear me?
Yes. Yes.
Yes, okay, thank you very much. Thank you again for the invitation. First question, how many people we have with a de novo metastatic hormone-sensitive prostate cancer? I think not so much because of early detection of the prostate cancer, and that is, I think, very good. So the number of patients with a primary progressive metastatic prostate cancer, hormone-sensitive, is, in my opinion, much more in Austria than de novo metastatic hormone-sensitive prostate cancer. The next question, you asked what I would do with a patient who is a low volume metastatic hormone-sensitive prostate cancer and high grade, so that's mean a high Gleason score, as I understand. As a Shariat, I think no. I think that operation also has a very important role for these patients, especially in the patients with a low volume and very aggressive disease, at least because of the local problematic. But in any case, as a state of the art at the moment, is not only because of a Gleason score. So we are looking on the patient's previous local treatment, yes or no. And if we have a de novo patients, so no previous treatment, we have a high, low volume disease. In this case, and probably you can do many things. It depends on the patient. So I think it's not a schema for treating those patients. We have to know patients, how old is the patient, what we expect, how big is the primary cancer, and so on. But one option could be in the low volume to treat first with a radiotherapy in the combination with ADT, and maybe after that to do some kind of the androgen receptor signaling inhibitors. But we will see what happened in the future with overall survival data from this study, from PEACE-1 study. So, but there is a no schema. We have discussed in tumor board every simple patients, what the patient expect, what is the patient's comorbidities, and so on, and then we decide how to treat these patients. In any case, not with ADT alone, if we have a possibility to make a combination treatment.
Thank you very much, Yasmin. Thank you very much again for an excellent talk from a wonderful speaker who is actually from Central Europe at the heart, you know, everything. So I wanted just to find out, in Innsbruck, you're really at the center of, you know, advanced cancer in knowledge, experience. Oligometastatic patients. When do you treat the single metastasis in addition to your standard strategies? Do you have a strategy for that? And is there like a stepwise approach to the local problematic if the oligometastases are well responding to the therapy, to your systemic therapy in general? Do you have a strategy for that in general, guiding strategy?
Okay. In any case, every patient, we discuss every patient first in the tumor board. Before I put the patient in the tumor board, I discussed with the patient already before what we can expect. If I have an oligometastatic prostate cancer and I have a possibility to make a radical prostatectomy, if the patient would expect the possible negative effects of or side effects of the radical prostatectomy, I would do that. What to do before or after that with a systemic treatment, it depends of the number of metastases we have. If you have the possibility to treat the patient after prostatectomy, not really only in the trial, to treat the patient after radical prostatectomy with radiotherapy in combination with ADT to lymph node metastasis or some bone metastasis. So we discussed really, it is not possible to tell what is the same for every patient. But I think if we want to treat the patients with a local treatment in the future, we do need PSMA PSMA staging before, so to be able to treat every metastatic lesion. If we want to do more than only cytoreductive radical prostatectomy, as you know, I do that, and I think that is very important. At the moment, we have only results for local problematic, but in the future, we will see there are many studies ongoing. What is with the overall survival, with progression-free survival, and so on.
Thank you very much, Yasmin. Again, thank you very much for your commitment to us, your time, and your excellence in what you're doing. Thank you very much, and warmest greetings back to Innsbruck.
Thank you very much for the invitation again, and greetings from Innsbruck to Vienna.
Thank you very much. So, interestingly, today we have a cameo, like a guest and a friend who is in town, and I just asked him to come on stage and also help us a little bit moderate the next lectures. Mohammed Abu Faraj is here. He's a professor at the University of Jordan, where he's been an excellent contribution to his country. He's spent 3 years with us, was certainly one of the foremost, most excellent fellows and really talented surgeon and also academicians. So he's in town, so I said, I forced him on stage and I said, come on, so you can introduce the next one and also gather a little bit of discussion, because it reflects the spirit of Central European society. I want to say our goal is to strengthen and bring the Central European community into the international community as leaders and partners. So we're reaching out here as well, let's say, to Jordan here. Thank you so much for being with us.
Thank you, Sharon. Glad. Thank you. Thank you for the nice introduction. I'm glad to be here, and I'm happy to introduce our next speaker, Professor Gero Kramer. He's a friend and a prominent urologist who specializes in uro-oncology at the Medical University of Vienna. He is actively involved in various key phase 1, 2, and 3 trials about advanced prostate cancer, and he participates in several basic and translational research projects. Today, he's going to talk about and give us highlights about practice-changing lessons in recent phase 3 trial in castrate-resistant prostate cancer. Can't wait to hear Professor Kramer.
Yeah, thank you for my first Jordan introduction, and also second, thank you for invitation to talk about castration-resistant prostate cancer as a kind of state-of-the-art or a kind of art. You know, I have Central Europe at home. I'm married with a Polish woman, so I'm definitely well prepared. These are my disclosures. Systemic treatment in metastatic castration-resistant prostate cancer in 2021. What are the learnings from recent randomized clinical trials? Well, therapies move forward from castration-resistant to castration-naive prostate cancer, thus affecting treatment choice in metastatic castration prostate cancer and change the disease. We have novel targeted drugs in metastatic castration-resistant prostate cancer, and we have new data on treatment sequence. This is a treatment landscape of advanced prostate cancer in Europe. And what you see is that the treatment of patients with metastatic castration-resistant prostate cancer depends on the therapies the patients received in the hormone-sensitive state. And this may be a double treatment with the different hormonal agents or chemotherapy with docetaxel, or even, probably in the future, a triple treatment with docetaxel and abiraterone. And then you have only radium-223 and cabazitaxel left in the metastatic castration-resistant prostate cancer setting. But we have 2 new agents, and I will come to that later. That's olaparib and PSMA lutetium. Non-metastatic, micrometastatic, if you will, castration-resistant disease. Which drug to choose? Well, the definition of metastatic disease is based on conventional imaging. That's a very important point. So definition is only based on bone scintigraphy or computed tomography in all randomized controlled trials. A patient with non-metastatic castration-resistant prostate cancer, and as I said, that's a radiological definition, is a patient at high risk of developing metastasis, but with currently no metastasis on conventional imaging, a PSA doubling time of less or equal than 10 months, and no or regional lymph node disease or pelvic lymph nodes smaller than 2 centimeters. We know that these patients have metastatic disease, but not detectable by conventional imaging, but detectable by a PSMA PET. So more than half of these patients have distant metastasis by PSMA PET imaging. However, that doesn't change treatment. We have currently 3 hormonal agents which prolong survival in non-metastatic castration-resistant prostate cancer setting. Darolutamide, as seen by the Aramis trial, apalutamide, seen by the Spartan trial, and enzalutamide, as seen in the Prosper trial. The difference between these 3 drugs is probably that darolutamide is a structurally different agent. And the most important point regarding different structure is that it has demonstrated a low blood-brain barrier penetration. And this is reflected by a probably lower incidence of side effects regarding mental impairment and fatigue, as seen here in the different groups which are compared to their placebo group. However, there are no head-to-head studies, and so we have to be satisfied with kind of indirect studies like matching adjusted indirect comparison, here done by Yang et al., showing that darolutamide has lower side effects concerning falls, fractures, and rash in comparison to apalutamide, and lower incidence of falls, dizziness, mental impairment disorder, hypertension, fatigue in comparison to enzalutamide. However, concerning efficacy, there is also kind of indirect studies by network meta-analysis comparing the efficacy of enzalutamide versus APA and darolutamide, showing that concerning metastasis-free survival, enzalutamide may be better than darolutamide, and concerning overall survival, no difference between these 3 drugs. So we need head-to-head studies to finally answer these questions. Which drugs to use in a metastatic castration-resistant disease? Well, this is a list of registration studies showing that the hazard ratio is between 0.6 and 0.8, with a pretty low increase in overall survival of about 3 to 5 months. But what you see is that all these trials were done in different states of disease, in different lines of disease of castration-resistant prostate cancer. And what you also see that we have different comparators, different inclusion criteria, different endpoints, and so the optimal sequence of these drugs in the castration-resistant prostate cancer setting is still undefined because of lack of head-to-head studies. And the overall benefit may be likely smaller in subsequent lines of therapy. And is there any benefit expected in the 4th line? But it's not so much a question which treatment, it's more questions if the patients get a treatment at all. This is the largest prospective registry study in metastatic castration-resistant prostate cancer with more than 3,000 patients, showing that not even every second patient receives any therapy after first-line androgen receptor-targeted therapy. A little bit similar to that what we've seen in metastatic hormone-sensitive prostate cancer. And this may also be because we are too late when thinking of giving chemotherapy to our patients, because there is also a PSA lower negative tumor progression, and there is even a clinical progression without a PSA progression and without a radiological progression. We should not forget that. What is new? Well, we have the first molecularly targeted therapy in metastatic castration-resistant prostate cancer, and this is based on the fact that in about 20% of these patients we have tumors with DNA repair defects. And PROfound was the first randomized phase 3 study evaluating the efficacy and safety of olaparib, a PARP inhibitor, targeting these DNA repair defects versus new hormonal agents in patients with homologic recombination repair metastatic prostate cancer. Mutations. Patients had to have at least one new hormonal agent to be included in the study, and it did not matter whether this was given in the hormone-sensitive or in the castration-resistant prostate cancer setting. And olaparib was compared in this randomized trial to physician's choice therapy, that is the other hormonal treatment, with a primary endpoint of radiographic progression-free survival. At about more than 4,000 patients were screened, and finally 387 patients randomized. This means that 69% were successfully sequenced, data which have been improved in reality, even in routine clinical practice, and about 28% had a qualifying homologous recombination repair mutation detected. And what you easily see is that the primary endpoint, progression-free survival, was met, 7 versus 3.5 months, hazard ratio 0.34. And this was also translated in a benefit in overall survival, and these are the data on these patients who have alterations in the BRCA1, BRCA2, or ATM cohort A. And there we have a hazard ratio of 0.65 and a median overall survival increase of 5 months from 14.7 to 19.1 months. And if you adjust for crossover, you even have a hazard ratio of 0.42. When the gold standard of tumor tissue testing, and that's what we need for the analysis of the DNA repair mutations, if this is not feasible, we can use circulating tumor DNA. This is one of our studies showing that the results of these patients who had BRCA1, 2, or ATM alterations in the circulating tumor DNA is similar to that if we found these alterations in tumor tissue. Olaparib is a well-tolerated drug. Also, urologists can give it easily with only minor side effects concerning anemia, nausea, and fatigue. But we have another targeted therapy, if you like, the first imaging targeted therapy in metastatic castration-resistant prostate cancer. And that is coming from the Vision trial testing lutetium-177, PSMA-617 in patients with PSMA-positive metastatic castration-resistant prostate cancer. Patients had to have at least one androgen receptor pathway inhibitor and 1 or 2 taxane regimens before they could enter the study. And they had to have a PSMA-positive spot on the PET-CT with gallium-68 PSMA-11. In this study, we have a 2-to-1 regime. Lutetium PSMA was compared to standard of care, which excludes chemo or immunotherapy. And the primary endpoint was an alternate endpoint, either survival or radiographic progression-free survival. And this is the classification if a patient could be included into the study concerning PSMA lesions. They have to have at least one PSMA-positive metastatic lesion with a higher uptake than in the liver, and no PSMA-negative metastatic lesions. These are excluded. And surprisingly, 87% of the patient met this criteria, so that there is even a discussion if you even need a PSMA PET. These are the results, and lutetium PSMA 670 prolonged survival met the primary endpoint with a hazard ratio of 0.62 and an increase in survival of 4 months. Also, radiographic progression-free survival was prolonged by a hazard ratio of 0.63 in a radiographic progression-free survival analysis set. What does this mean? The problem was that in the beginning of the study, there was a high dropout rate in the control group. So there has a second educational setup for all the study centers and a new evaluation, at least regarding the radiographic progression-free survival, only with the setting of the patients who received treatment after this educational setting. Lutetium PSMA also met a lot of secondary endpoints, and look how 50% of the patients showed an objective response. 10% of the patients showed a complete response. And if you look at the PSA confirmed decrease rate, you have a 30% decrease rate of more than 80%. And this at the cost of very few side effects, only bone marrow suppression, and some small renal effects and dry mouth. What about the re-challenge of hormone treatments in metastatic castration-resistant prostate cancer, something which has been heavily discussed? Well, the absolute killer for a re-challenge of hormone treatments is the CAR trial. The CAR trial is a randomized trial comparing cabozantinib with abiraterone or enzalutamide, depending whether the patient had received abiraterone or enzalutamide in the pre-study setting. And these patients had to have a progress within 12 months of prior ARTA. And what this study shows is that the radiographic progression-free survival and the overall survival favors chemotherapy versus the alternative hormone treatment. So this clearly shows that re-challenge of ARTA is not allowed anymore. Interesting also the adverse events, because beside the awaited adverse event of febrile neutropenia with only 3.2%, we have cardiac disorders 5 times higher in the Abiraterone group compared to the chemotherapy. And that's something which we have to do in our clinical practice to monitor these patients on a regular basis concerning cardiovascular morbidities and the right medical treatment. What about bone protection in metastatic castration-resistant prostate cancer? Well, there are a lot of studies. We know that we have to do it, at least after the ERA trial with radium-223 and abiraterone, as you probably will know. There is another study, comparing radium-223 with enzalutamide versus enzalutamide alone, and this is an updated safety analysis by Silke Gillison showing that if you have no bone protective agents, you have a fracture risk of 16% for enzalutamide. But with bone protecting agents, you have a fracture risk of only 2.6%. What should you take home? Treatment of metastatic castration-resistant prostate cancer has become a rapidly changing field. With novel targeted therapies with olaparib and lutetium PSMA 617. Do genetic testing and molecular imaging in your patients. No androgen receptor targeted agents after androgen receptor targeted agents because of cross-resistance. Monitor the side effects of androgen receptor targeted agents and protect bone health. And there's an urgent need of head-to-head studies. Some thoughts on future perspectives. We have to prevent or postpone castration resistance as much as possible by early treatment, combination cocktails, and more agents that do not target the androgen axis. We have to go to the neoadjuvant and adjuvant setting. Immune axis targeting agents are one key, starting before subclonal expansion the other. And who explores early pathways of tumor origin in prostate? Shouldn't we as urologists participate? Thank you very much.
Thank you very much.
Thank you very much for Professor Kramer for the introduction, for this lecture. And I don't know if you have any question for him. Then we proceed to the next speaker.
Just very short question regarding to lutetium, because there are too much problems if this treatment is feasible for these patients. Do you use this treatment regularly in Austria, or is it on experimental treatment?
Okay, we use bone protecting agents on a regular basis, but as you have seen in the studies, in the phase 3 studies, obviously we all didn't. And if you ask the opinion leaders afterwards, they said, okay, I didn't do that on a regular basis before, but now we try to do it. And of course you have to put these patients on calcium 1 or 2 grams in combination with vitamin D.
Thank you. So I would like to introduce next speaker. Thank you very much. I'm sorry.
It's okay. Yeah. It's okay. Thank you very much. I've received the privilege, and I'm honored of that, to introduce Professor Harun Hajkovic from Department of Urology at the Medical University of Vienna, my close friend. I'm proud of that. One of the master and much expertise in oncologic surgery urologist, and he's also interested minimally invasive surgery. Currently, he's doing a Master of Science in Gender Medicine at the Medical University of Vienna. I know Professor Hajkovic as a close friend, as a urologist. Who is always genuine on human problems. Great surgeon in the highest level of ethical activity and the highest level of the science. Professor Hajkovic will talk about very, very complicated surgery, and the surgery which has all the benefits for the survival for the patients. Tips and tricks for the caval thrombectomy in renal cancer patients. Harun, the floor is yours.
Dear Piotr, thank you for the nice introduction. Thank you for being here today. Thank you for inviting me and giving me a chance to talk about it. I will talk today about caval thrombectomy, as you said, technically highly complicated part of the renal surgery. We will start just to understand it, the way how I learned that in a few institutions I was working till now, because the caseload of that entity is not high, doesn't matter where you work. Those kind of surgery you can have in renal cell carcinoma, but not only, as you can see on this slide, in Wilms tumor, in a non-seminoma, in leiomyosarcoma, upper tract urothelial cancer, and so on. First, to understand what the goal is the big difference. If you take a look at this Hafecam paper, you will see a big difference between patients who received surgery compared to patients without surgery. It means a proper surgery, radical surgery, brings benefit in survival. The symptoms of the IVC thrombus you can see in this table, but I just want to remind you and to remember you. On the left, varicocele. I'm always saying to our residents, if you do ultrasound and see a left side varicocele, think of the kidney and take a look of the kidney on the left side, which is anatomically explainable. Evaluation of the thrombus. If the patient comes with a thrombus, you will mostly find it as some result in a CT. You will have to deal with MRI, which is for a lot of urologists not really common. Also not for me. In the kidney surgery, we are performing 99% of CTs, and this case of the caval thrombus needs MRI. Why? Because we need a proper evaluation of the tumor thrombus, not only of the tumor thrombus. Because of few small things you will see in the slides afterward. It is not only important to see how big the thrombus is, it is important to make a differentiation between a tumor thrombus and a physiological thrombus, which can be attached or sticked to a thrombus. And it is also really important to see if the blood flow is still here, or the thrombus is occluding a vena cava completely. As you can see in this picture, this is a collateral veins on the left side of the patient. Bland thrombus, this is the black thrombus in MRI down in the inferior cava, and the level 2 tumor thrombus with the partial occlusion. That means blood is still coming through the kidney. Why is that important? You have to be sure that your pictures are fresh, or better to say, you should take care about the pre-staging or staging of the patient pre-surgery by yourself, because you can have a really fast progress of the disease inside of the weeks. In 20 days, in this picture, you see complete occlusion after 3 weeks. The question I'm always or quite often confronting is if you should use IVC filter preoperatively, and I think mostly no. I will show you why. I'm talking about preoperative. Just for remembering, 4 stages of a tumor thrombus, right side kidney tumor, 1, 2, 3, 4. Till 3, I would say you can manage it by yourself with the help of the hepatical surgeons, eventually also vessel surgeons. But for 4, you will also need a good cardiac team. I will show you the methods we are using, or tricks we are using, or our cardiac surgeons are using. Also, the stage of the disease is varying and will be more complicated with a higher stage of the tumor thrombus. Which are the candidates for non-operative management? And I will show you what does it mean. These are the patients with diminished cardiopulmonary function, with poor performance status, acute fulminant Budd-Chiari, or bulky critical metastatic disease. These patients should be identified before surgery. And now is the question, of course, what you can offer to those patients. And the second question, if you go with some conservative oncological management, if you can secondary offer a surgery. I will show you just 2 papers about it, because the euphoria about the paper of Pierre Karakiewicz more than 10 years ago was high, because that paper in European Urology showed actually excellent results on perioperative or neoadjuvant, if you want that way, because the patient was not metastatic, giving sunitinib. I tried that few times afterward in patients which had a bad ECOG performance status, or patients which were not given free from internal medical doctors for a surgery. And those good results, like you can see it in this publication, I was never faced. I never ever saw this kind of answer of biology of the tumor to a perioperative sunitinib. Second case I want to show you is also just a case report with complete response of renal cell carcinoma, vein cava tumor thrombus to neoadjuvant immunotherapy. It's something what we are trying now, and I'm really happy to have Manuela with us on board and in the team. I'm discussing a lot of patients with her, and she's also bringing patients I would never see with that. I can show you some picture of the surgery after Manuela did neoadjuvant. We still didn't find the perfect candidate to let's say, publish something like that or go out with the data, but we are working on it. This slide is from a friend of mine, Sharok Shariat, who went to the class with Albert Einstein, and Albert gave him this slide, and now I just took it from Sharok. Make things as simple as possible and no simpler, Albert Einstein. Means, and these thoughts are from Sharok, from his time on Memorial Sloan Kettering, when he dealt with those tumors with James Eastham. No meds, and this is old, I can say old now because Sharok is already almost 10 years here. I can say old knowledge from that time, but it didn't change. Even in the time we have immune therapy, means no meds, resection preferred. Be aggressive. Poor surgical candidates, systematic therapy. Now the question I was already facing before, which one, which patient, biopsy, no biopsy, this is why we are having Manuela. And with meds, performance status, Relative burden of disease determined pre versus operative, post-operative versus systematic therapy alone. That means you have to think. With meds, you have to think a lot. That's why I think also that it's very good to have multidisciplinary teams like we are having now for kidney surgery at least. Surgical principles, tips and tricks, what I was promising for tumor thrombectomy. This is the main slide. This knowledge you can have in every, or this kind of strategy you can use for every caval thrombus in a RCC. You have to have experienced team. One surgeon alone is not enough. You need a good anesthesiologist, eventually hepatobiliary surgeon, vascular surgeon, or cardiac surgeon, depends on the grade of the tumor. Operate on vessels first. You have to really be fear has nothing to do with the caval thrombus surgery. That means you have to be fearless of bleeding, you have to be fearless of resecting vessels, and doesn't matter how good you do, you will have 2-3 liters in a sucker. That means you have to be a kind of team, or you must have a kind of team who is able to deal with such stuff. Ligate renal artery, no need to embolize. That means you should take a renal artery first in a normal manner, use manner for every urologist who is doing renal surgery. After that, isolate the venous structures. Depends, of course, how much is involved, how much of the collaterals are also strongly there. Manage any distal blunt thrombus. I will show you some pictures what I mean with that. Repair patch, replace IVC as needed, mostly through vascular surgeons, and complete nephrectomy and RP-LND at the end. For level 1 and 2, some more tips and tricks, especially for level 1 and 2. Occlude renal artery first, as I said, ligate hepatic veins from caudate lobe of liver, and simple occluding maneuver, contralateral vein of IVC inferior and superior to thrombus, as you can see on these pictures. For level 3, a little bit more advanced because you have to go upper of the liver. That means from the point 3 here, hepatic inflow, Pringle maneuver, and suprahepatic IVC above thrombus. Remove thrombus, cut the cava, remove the thrombus, occlude IVC below hepatic inflow, release suprahepatic IVC and Pringle, repair vena cava lesion, and complete nephrectomy at the end. This is something like that. This is a cava thrombus level 3. You can see liver is mobilized. You can see that the hepatic vein with the upper Pringle is under control, and you can see the situs completely controlled situation. Surgical principles for level 4. I'm one of the happy surgeons to work in AKH and have really big teams around me in every clinic, and we are working together with thoracic surgery, and they are offering us a lot. Venous bypass or cardiopulmonary bypass, even cardiopulmonary bypass with hypothermic, 160 degrees Celsius, circulatory arrest. What makes it possible to work for 60 minutes on ischemia time. Hypothermic arrest is associated with longer oral survival and significant reduction in the perioperative mortality in patients who are having a cardiac level 4 of the thrombus. As I said, I understand that some of people will say we will not do it, or we will do it a different way, but if you're working on such a hospital, high-end hospital like I'm lucky to be there, then you can do the things like this with the help of friends from other departments. Our standard von vena cava patch, as you can see it here, if you have to do it by yourself, just cut it, always cut it a little bit more than you think that you will need it. It means this patch, you will think you need it smaller than it is. Take it bigger and you can still cut when you start suturing. What we are using mostly is a pericard. It's a bovine pericard to make a patch on the vena cava. If you have to remove the cava and the patient is not that kind of patient with a lot of collaterals, then you will have to replace the cava. This is our standard system. Maximum size is 20 millimeters in diameter, and you can make a bypass or to do even a bypass of the contralateral kidney to such kind of the grafts. This is what our vascular surgeons are performing with us in that cases. I just wanted to show it. Think about venous supply of the kidney and the retroperitoneum. That's why I have this slide. Of IVC occlusion means if it's a complete occlusion, 100% occlusion of the vena cava, and patient is coming to a clinic, that means some kind of collaterals should work, otherwise it will not be possible that patient comes to you. For such of situations, I have this slide, a young patient I did like 2 years ago, and if you take a close look to this picture, that was the patient with level 3 thrombus, but complete occlusion. Like 70% of the thrombus was physiological thrombus, not a tumor thrombus, but anyway, that was a complete occlusion. And if you ask yourself, or if you're searching for the vena cava, I can show it to you. This is vena cava. It's ligated and resected. That means sometimes if you see that venous system is enough, or it's good enough with the collaterals, you can even resect a vena cava with the thrombus and without to do a graft. That's what I did in this young man. The biggest problem for me in that case was to preserve all the veins around. Actually, during I was cutting the muscles. That means epigastric vein and the veins around the fat. But this is a doable way. Resect a cava without a graft if occlusion is 100% and the collaterals are here. For post-operative, as I told you first, I don't see a much benefit of renal cell I'm searching now for the English word umbrella. I wanted to say, let's call it umbrella, like a Sherm in German, to preserve the thrombus coming in the upper system. Maybe this slide will help you, because you will see that there is maybe much more benefit of post-operative use of a filter. As you can see in the side B, after you did the left side tumor thrombus and down you have a thrombosis, it could help you, or it will give you a safety, to patient safety, that deep thrombosis from the iliac veins will come to the heart. That means post-operatively, after the surgery, I see a lot of benefits using a Greenfield filter, but not really before going through the cava thrombus. What is about the prognostic factors in this disease? Plus or invasion of the renal vein. That means if a thrombus is really connected with the vein, it's a negative predicting factor. Invasion of the IVC below the diaphragm or invasion of the IVC above the diaphragm, you can see it in the slide, is making also some significant differences in Wagner paper, Urology 2009. But the only significance in survival you will see is in lymph node metastasis and distant metastasis. And if I'm coming back to Albert Einstein slide, it's exactly like guys from Memorial said like 10 years ago, without that kind of statistically relevant. No mets, good, bad, with mets, with lymph nodes. If you go for another one from Bertini in 2011, you will see that there is also a showed difference between solid and friable tumors. That means the consistency of the tumor thrombus affected survival too. Even in this paper, even significantly. Friable, much worse than a solid. Solid one you can remove much easier than a friable. But the next slide, from Journal of Surgical Oncology from 2016, will show you no predictive value or no difference between friable and solid in 413 patients. However, we are also looking at that, and we will go out with our results, but I can tell you preliminary, we also don't see really a big difference if you do a surgery aggressively and remove even a friable tumor thrombus. If you remove it really categorically without to think if you will even resect a cava, then we don't see that differences in survival. Conclusion. Surgery can provide durable survival in node-negative patients without mets and remains preferred approach. Yes, agree. Meticulous attention to management of vascular anatomy is mandatory. Yes, please, you have to understand that unique anatomy of venous system, mostly of the venous system of your patients, and the occlusion degree. Experienced multidisciplinary team can assure low morbidity and mortality. Integration of systemic therapy will improve survival, especially for node-positive patients, I'm sure, but we have to wait. Manuela will tell you something about it. Take home. Look for the thrombus on every case. By yourself, if the MRI is old, do a new one. Drugs and time usually don't improve the situation. Don't think that you will buy time giving drugs to patients without meds and without lymph nodes. You have to go for the surgery. Consider yourself as a urovascular surgeon. Take care of artery, then vein, then kidney. Assure venous return during case. Think about how you will completely clear the tumor. Thrombus with negative margins and prevent emboli, even if you pay a high amount of money for that, as you could remember on the slide when we resect the cava without anything. Combat nihilism and remember outcomes can be very good. Thank you very much.
Thank you very much, Harun. It was an excellent talk. Provide back excellent surgeon with the big experience in one of the most challenging kind of the surgery. Professor Minczyk, even, do you have some question?
Only one short question.
Yes, please.
As Peter mentioned, you are an excellent surgeon because you are doing very difficult cases. I have a question regarding to embolization renal artery before removing of kidney and doing thrombectomy. Do you think is it a good idea to do it embolization to improve removing of kidney to shortening of time of surgery? Just to
No. I used to do that 10 years ago in this institution few times, and I was thinking maybe it's good, but after I realized that is not helping anything. You go to artery, you do artery first, you don't care what is with the vein system, you just occlude artery, and I need for that like 15 minutes. I don't see a really benefit, except that patient could have pain through the night, through the necrosis, that you cannot cut through the artery. Maybe on that point you would like to cut because the embolus is inside, and. I don't see really any benefits of doing an embolization of the artery. I cannot recommend that. I would say don't do it.
Okay. I have a question also.
Yes, please.
Okay. Thank you, Harun, for the nice talk. Amazing. You have just said that in the take-home message that look for the thrombus in every case, but this question is for junior urologists. What if the thrombus finds you while you are doing a regular case? Imaging was not suspicious. You try to put the clamp, you try to put the tie, and you face a thrombus. What do you recommend?
I do understand you. I understand what you mean. That scenario you are asking me should not happen. That means in Europe or in Austria, in Vienna, it's not possible. It happens. If that happens, I have to quit my job next day. If we put the kidney on the schedule and not know that we have a thrombus inside, that means my job was not good, that we didn't concentrate on the meetings we are doing before we are taking a look of the pictures, or I'm never letting through 3 months old picture of the kidney. Not even in 3 centimeters. I said, okay, guys, let's take a closer look. And if you have wanted to ask me now, if a kidney tumor is like 3 centimeters, but the cava thrombus is like 5, I never saw it, but it's maybe possible. And in some different, let's say, system, I could imagine that something like that happens. Only one thing is important in that question. If you realize during the surgery on the kidney that you have a thrombus and you didn't know you have it, you should not cut through the thrombus and don't tell to anyone. If you're not able to cut, then call somebody who is. But don't do and don't pretend there is no thrombus, because you will kill the patient. Do whatever you want. Call the senior guy, open it and take it out, leave a liter of blood, all good. What is not good is to put a clamp to take out the kidney and pretend you never saw thrombus. That is wrong.
Absolutely right. There is a strong take-home message: remove the kidney and leave the thrombus. It's a catastrophe for the patient.
Something
Yeah, absolutely.
You have to fight.
Absolutely. Now we are moving the microphone to Professor Minczyk.
I'd like to
thank you, Harun.
Thank you very much. Thanks a lot.
So now I have great pleasure to introduce to the floor another great expert, Professor Manuela Schmidinger. She is a professor of medicine and she is specialized for medical oncology and intensive care of medicine. She has very great activity in academic field. She has a lot of publication in more than 100 articles, like Journal of Clinical Oncology, New England Journal of Medicine, and she is also co-author of European guidelines for kidney cancer, which are very important for urologists and medical oncologists. And she will have her lecture, which is related to metastatic kidney cancer. Also, this is a state-of-the-art lecture. Please, you can start your lecture.
Thank you very much for this kind introduction and for inviting me to this meeting. So today I have selected those topics. First, the question, can we prevent metastasis after surgery of localized kidney tumors? What about the role of cytoreductive nephrectomy after the CAMINA trial? What to offer in the first-line metastatic setting and beyond first line? What to do about patients with non-clear cell RCC? And which of the strategies from the past actually are still relevant today, and what are future strategies? Let me start with the question, can we prevent metastasis? And I'd like to start by showing you the scan of a patient of mine, a female patient who underwent laparoscopic nephrectomy in 2021. So this was a clear cell RCC grade 4 with sarcomatoid features and necrosis. And what we know when we see this histological report is that she has an extremely high risk for relapse, that her relapse is actually expected to occur within less than 2 years, and her 5-year metastasis-free survival is just 30%. Adjuvant treatment for such a patient? Of course, you would say, if we had an adjuvant treatment that makes sense. And in fact, tyrosine kinase inhibitors have been investigated versus placebo in 6 randomized trials. But only one trial met the primary endpoint of prolonging significantly disease-free survival versus placebo. This was the ESTRAC trial using as a TKI sunitinib. And still this trial did not lead, at least not in Europe, to a recommendation in the guidelines for adjuvant TKI treatment. At ASCO this year, we have seen in the plenary session a completely new strategy in the adjuvant setting. And this is the strategy of using an immune checkpoint inhibitor, in that case pembrolizumab, in patients who had the surgery of the primary tumor not longer than 12 weeks behind them. And high-risk patients were included. So how was this defined? You can see here the definition that the authors of the trial decided to go for, and the red stars indicate that these patients were not included in the ESTRAC trial that I just mentioned before with respect to sunitinib. Disease-free survival was shown to be significantly improved with pembrolizumab versus placebo with a hazard ratio of 0.68. We can also see that actually the curves separate quite early. When we look at the subgroups, the best outcome, let's say the highest risk reduction, was achieved in patients who had M1 disease, in patients who had an expression of PD-L1 on the tumor, and interestingly, for unknown reasons so far, in the EU. What also was kind of perceived as encouraging from the audience was the interims analysis of overall survival. It's not mature yet, but what we can see is a separation of the curve around 15 months after starting the treatment. So this is at least an interesting signal that may kind of encourage us to believe that we will eventually see a survival benefit. Another important aspect, and this is probably relevant to answer the question, will that become an adjuvant standard of care in kidney cancer, and will that be approved and also recommended by the European guidelines, is the safety profile. Sunitinib, one of the issues with sunitinib in the adjuvant setting was that grade 3 and 4 adverse events were seen in 60% of patients, while in this trial here, only 18% of patients experienced grade 3 or 4 toxicities, and there were no treatment-related deaths. Therefore, I believe there is a good chance that the European kidney societies will encourage the approval and recommendation for this treatment. Let's also talk about cytoreductive nephrectomy and my view as a medical oncologist on this issue. And again, I'd like to start with a patient of mine. This is a medical doctor who has his own company. He's self-employed, and his first symptoms of metastatic disease were in September 2009, when he had a recurrent pneumonia, and he only treated himself for a year with antibiotics. Eventually, he went through some investigations, and in September 2010, 1 year later, he was diagnosed with this large kidney tumor. And why do I say that the pneumonia was related, already a sign of metastasis? Well, because there was a quite huge thoracic lymph node that caused atelectasis and recurrent pneumonia. So these were his characteristics. He was classified poor risk according to the IMDC criteria. You also can see the original lab below, and the histology was clear cell RCC. So according to what we have learned from the results from Carmina, this patient should never undergo cytoreductive nephrectomy. Carmina has shown that the median overall survival with sunitinib is numerically longer than with cytoreductive nephrectomy followed by sunitinib. And then I still feel that Carmina kind of failed to induce a complete change of paradigm. I would say it didn't fail as a trial per se, but there were many open questions, and these are the main factors. The trial took 8 years to enroll patients, and that already suggests an enormous bias by patient selection. Also today, sunitinib is no longer our standard of care for intermediate and poor risk patients. Then, in the sunitinib plus cytoreductive nephrectomy arm, 9% did not undergo cytoreductive nephrectomy, and 18% did not receive sunitinib. And in the sunitinib arm, 5% did not receive sunitinib, and 17% did undergo surgery. Also, we need to be aware that the median overall survival of patients with only one IMDC risk factor was longer with cytoreductive nephrectomy. Intermediate risk patient with lung mets only survived longer with cytoreductive nephrectomy. And in general, what we can learn from that trial, and this is probably the most important finding, is that the longest OS actually was observed in patients with delayed cytoreductive nephrectomy. And then what also kind of increases our doubts on the outcome on the results of this trial, and this is also again an analysis that was presented at ASCO this year. This is an analysis on the survival benefit of nephrectomy prior to immunotherapy-based combinations. 1,700 patients, the results from phase 2 and 3 trials submitted to the FDA were analyzed and with respect to the outcome by prior nephrectomy. And what you can see here is that the overall survival is improved with cytoreductive nephrectomy with a hazard ratio of 0.53, and even after adjusting for age and prognostic factors with a hazard ratio of 0.59. So my patient actually had a lot of surgeries. He first underwent cytoreductive nephrectomy, followed by sunitinib. He then had a metastasectomy for thoracic met. He continued sunitinib. Then he progressed, received another TKI. Then he had a second metastasectomy, continued TKI. Then he needed a debulking surgery because of a large lymph node metastasis. He went back to TKI treatment. This had to be discontinued because of an abdominal wall defect for a year. And when he progressed in the liver, when he progressed with a lymph node, with an abdominal lymph node, he was referred to radiofrequency ablation. And then we also decided, when he had a liver met, to do an RFA and to offer him nivolumab in the pseudoadjuvant setting. And then this treatment was discontinued in May 2017 for immune checkpoint inhibitor-related neurologic toxicity. He has been off treatment since May 2017. His neurologic toxicity resolved only 1 year after discontinuation of checkpoint inhibitor. But he has been no evidence of disease since August 2015, and his third-line progression-free survival since RFA and third-line nivolumab is 6 years, and he has been alive so far with metastatic kidney cancer as a poor-risk patient for more than 12 years. So you can see that there are multiple cases also in your own practice probably where you can say for you the story about cytoreductive nephrectomy is not already written. What about first-line treatment of metastatic RCC? These are the current updated guidelines. You will find them soon online. And as a first-line treatment strategy, we have for all IMDC risk groups either axitinib combined with pembrolizumab or cabozantinib, the MET and AXL VEGF inhibitor combined with nivolumab, or the FGF and VEGF inhibitor lenvatinib combined with pembrolizumab. And in addition to that, for the intermediate and poor IMDC risk group, you also have the option for nivo and ipi, and all recommendations are 1A. So we have basically 4 competing strategies for intermediate poor risk and 3 for favorable risk. I'm not going to show you all the data of these trials. You can read them on your own. Just to summarize it, the response rates with these new strategies went up to 70%, the CR rates up to 16%, progression-free survival up to 24 months, and all of these trials significantly improved overall survival. When we kind of cross-trial compare here, then we need to be aware that these trials differed with respect to patient characteristics. For example, axipembro and lenvatinib pembro had the highest number of patients with favorable risk, and lenvatinib pembrolizumab the lowest number of poor risk patients. Nivo-ipi and axipembro had the highest number of patients who had undergone prior nephrectomy, and also with respect to PD-L1 status, the trials appeared to differ. What can drive your treatment decision? At least 4 possible parameters. Are you striving for long-term survival, or do you need a very fast activity and prevent death? Are you going, in other words, for heads or tails of the curve? We have learned that with Keynote 426, we have a median follow-up of 42 months. And here it seems that in comparison to the CheckMate 214 trial with nivolumab ipilimumab, it appears actually that the ipi-nivo tail is higher than the tail of axipembrolizumab. Another thing that can drive your treatment decision, maybe it is the likelihood of response or complete response or the response duration, or it can also be the other way around. You say, which is the treatment that is less likely to cause or to leave me with disease progression despite treatment. So the highest OR rate was seen with lenvatinib pembrolizumab, the highest CR rate as well. Duration of treatment, however, the longest so far with nivo-ipi. And nivo-cabo and lenvatinib pembrolizumab are 2 strategies that really allow very, very few patients to progress during the treatment. Quality of life could be a driver of your treatment decision. Only CheckMate 214 and CheckMate 9ER have shown statistically significant and clinically relevant improvement in quality of life. Finally, sarcomatoid features can be a driver. Cabo-nivo had a quite impressive hazard ratio for progression-free survival, for median overall survival in this context, 0.36. But also very interesting, and probably even my preferred regimen here would be nivolumab ipilimumab, with a median PFS in patients with sarcomatoid features of almost 27 months and a CR rate of 19%. What to do when a patient progresses on such a great treatment that we have to offer today? The treatment algorithm here is not very precise. So the treatment algorithm says offer a VEGFR systemic therapy that has not been given previously. That could include any of those TKIs. All are 3B recommendations. I think some are likely to become more important than others if they have not been used in first line and if confirmed in larger trials post immune checkpoint inhibitor. This is cabozantinib, which was shown to trigger partial remission in 43% of patients, and the combination of lenvatinib plus pembrolizumab, so a reinduction with immune checkpoint inhibitor, with a partial response rate of 56% and a PFS of 11 months. What to do about our patients with non-clear cell histology? Here again, the current treatment algorithm. So for first-line systemic therapy for advanced papillary RCC, today cabozantinib is the preferred option, and there is nothing specific that is recommended after failure. Why is cabozantinib the first-line treatment of choice today? This is based on the results that Sumanta Pal presented at ASCO GU this year. This was a randomized phase 2 trial on sunitinib versus 3 different MET inhibitors. We know that that papillary type 1 and sometimes also papillary type 2 is driven by MET expression. So this was a trial with 4 treatment arms. Only cabozantinib and sunitinib remained. The others were closed due to futility. This was a randomized trial, and you can see that cabozantinib was clearly superior with respect to progression-free survival. Also, some patients achieved a complete response, at least 5%, and partial response rates were high, also with 18%. Other non-clear cell types, for example, collecting duct data from ASCO, the Bonsai trial, a phase 2 trial, demonstrated that cabozantinib is active in collecting duct with a response rate of 35% and even one complete response. In unclassified or translocation-associated and chromophobe RCC, cabo-nivo was tested in a phase 2 trial. In the unclassified cohort, it worked well. However, you can see with a response rate of 47% and a PFS of 12 months, but no benefit was observed in the cohort of patients with a chromophobe. A very specific histology is the HLRCC-associated papillary RCC. You know, HLRCC is a familial disorder with germline loss of function in the fumarate hydratase gene, leading to increased HIF levels, which predisposes for aggressive papillary RCC. And this was actually just a phase 1 study with bevacizumab erlotinib in this very rare disease. The primary endpoint was objective response rate. And you can see, and this is what is shown in yellow here, the response rates in HLRCC was 72%, even with CRs in almost 5% of patients, and the median progression-free survival 21 months. And the authors concluded that this is kind of a new state-of-the-art, although this is just a phase 1 trial, but nevertheless consider how rare this tumor is. Therefore, I can say I would support and encourage this view. Finally, the remaining and future strategies. Remaining strategies will always be active surveillance in metastatic disease. We have learned from one trial that the median time on surveillance from registration on this phase 2 study until initiation of systemic therapy is almost 15 months. And what also remains from my point of view is the topic of metastasectomy and other local treatment approaches. This is a large meta-analysis, again highlighting the benefits in terms of overall survival from different studies conducted. And the median overall survival goes up to 142 months in patients who undergo complete surgical metastasectomy. And metastasectomy also remained independently associated with a reduction in mortality across all subgroups. New strategies in terms of agents. We have a new selective HIF-2 alpha inhibitor, the belzutifan. We know that this is addressing the basis of clear cell RCC. These tumors have a defective VHL function. And belzutifan is currently under investigation in phase 3 trials, but the signal that we have received from as a second-line strategy from smaller trials is quite interesting. Response rate of 25%, PFS almost 15 months. And on August 13, belzutifan got FDA approval for VHL disease-associated clear cell RCC with a response rate of 50% and also quite impressive responses in lesions outside from the kidney. Finally, microbiome manipulation will become more and more important. This is a randomized trial from ASCO, just a phase 1b study. Nivo-IPI plus microbiome manipulation versus Nivo-IPI alone. And you can see that response rate and progression-free survival and overall survival appear significantly increased with manipulation. So to summarize, pembrolizumab demonstrates improved disease-free survival versus placebo in high-risk localized RCC and in M1 resected patients. The patient selection will be crucial. In contrast to adjuvant atezolizumab in resected urothelial cancer, we need to be aware that the detection rate of circulating DNA is quite low in kidney cancer. I also believe that the neoadjuvant and combination approach will probably even be better. At least the xenograft models show that this is a better approach than the adjuvant option. Cytoreductive nephrectomy for intermediate and poor risk patients remains under debate. We have 4 first-line strategies in clear cell RCC. Tumor and disease characteristics drive the choice. I think active microbiome manipulation may become a standard of care. For VHL syndrome-associated RCC, belzutifan is the new standard of care. Second line, what has not been given before is a recommendation, but cabo and lenvatinib pembrolizumab are quite promising. Non-clear cell, cabozantinib is the new standard of care, also in the guidelines in papillary RCC, and erlotinib plus bevacizumab have shown unprecedented response rate and PFS in HL-RCC. Chromophobe RCC unfortunately does not benefit from IO treatment. Active surveillance and metastasectomy remain options in selected patients. And more recently, it was a very important paper published in Cancer Cell. Bob Motzer performed a large analysis, genomic analysis on more than 800 RCC tumors and was able to identify 7 different subtypes associated with different outcomes to VEGF blockade alone or in combination with checkpoint inhibition. And I think we are more and more driving toward offering personalized medicine in metastatic kidney cancer. Thank you very much for your attention.
Thank you very much. It was again a fantastic lecture, a lot of information. I think that the Department of Urology in Vienna has to be very happy that you have that they have such expert for treatment of oncological patients with kidney cancer. I have only one simple question. You have mentioned first line of therapy for advanced kidney cancer with metastasis. Do you require always biopsy, histological biopsy, to confirm the type of cancer, and then you decided for the type of treatment, or you can start this treatment without biopsy?
I would feel more comfortable to have a clear histological report for many reasons. And also, for example, if it was a papillary RCC, then I would clearly choose a cabozantinib-based regimen rather than a pure VEGF inhibitor in combination with whatever. And therefore, yes, definitely the histology report is very important.
Okay, thank you.
Thank you so much, Manuela. Really a fantastic lecture again with an insight and knowledge that is unique, that only truly in the world you have. The question I have, a little bit looking towards the future, concepts of novel concepts moving beyond surgery, radiation, other concepts to even, concepts how to make the immunotherapeutics more active, better, in addition to the microbiome manipulations. Are there any things that we can today already, or we see coming along?
Absolutely. So, because you mentioned radiation therapy, there was actually a paper also recently, a small trial where different cohorts of tumors were included and where radiation was combined with immune checkpoint inhibitors. This was in tumors with cava thrombus. And interestingly, what really could have been shown was not only a downsizing of the thrombus and the tumor, but also this also called abscopal effect, where distant metastases disappear, although they were outside from the radiation field.
Then another field that you are really keen on and you really work hard. What do you tell your patients in addition to the standard therapies? what is unique to you, you're not looking at a cancer and only its genomics, but you're also looking at the whole patient. You work on a microbiome. What else do you tell the patients a little bit to get the best optimal results, for example, whatever therapy?
Yeah, so actually I also encourage the patient to do some exercise, regular exercise. We know that TKIs are kind of triggering a loss of muscle, and this is important that patients exercise. And we know also from different studies that any kind of exercise also increases the response of the immune system to the tumor and improves the immune response. So this is something I also definitely would encourage a patient to do. And actually you can exercise at any age, it's not a matter of age.
Diet changes in addition?
Diet changes could be interesting. So the field has been, there was a lot of research already done in this field, and it appears that things like intermittent fasting could also be of benefit. This was shown in so far in the xenograft primarily, but nevertheless, all these studies that included fasting kind of had positive signals, but it was not yet investigated in large randomized trials.
Fantastic. Thank you so much. You know, really not only a pleasure every day to work with you, but really an honor, because we learn always more, and the field is moving forward and it's really getting leap and bounds improving. Thank you so much for being with us today. The next lecture we're going to have, it's going to be a pre-recorded lecture by somebody who's very dear to my two friends and to me, somebody who's unique, also one of the founding members of the Central European Urologic Society, somebody who has really provided us not only with leadership, vision, but also with a warm heart and energy to move forward and to bring not only the region together, but to move towards really excellence in the region. Marco Babjuk is the chairman in Charles University at the Motul Hospital. He leads the Department of Urology. He is also chairman of the Czech Society. He has many roles. He is also the head of the EAU guidelines on non-muscle invasive, which he single-handedly really pushes forward. And he has many other functions and has been really a human par excellence that has been unique and really forward-thinking. So we asked him to give us a talk on a subject that is very rarely discussed, but is quite important to the individual patient today more than ever before, since we can achieve cure today at a higher rate than before. So quality of life matters more in patients undergoing radical cystectomy for muscle-invasive disease. So his talk is going to be on sexual function preservation during radical cystectomy. Thank you, Marco.
So good afternoon, everybody. I would like first thank for invitation. It's a pleasure to be here with you. I would like thank organizers for doing such a wonderful meeting. I would like thank particularly Sharok for his effort to continue with our Central European activities, and I hope we will meet physically again next year. But my task is to talk about the sexual preservation during radical cystectomy. Talking about radical cystectomy, we need to remember what is the goal of the surgery. And the primary goal is achieve a long-term survival. So we need to cure the patient to have a good oncological results and prevent all post-treatment complications. But there is also the secondary goal, which is secondary but also important, and this goal is to achieve a good quality of life. And particularly in younger patients, we must remember their body imaging and preservation of sexual activities. We should really reflect their desires. We know today how we can achieve the optimal oncological results. First, we need to perform cystectomy before extravesical extension, and also we should have an adequate extent of surgery. And we know how important it is to have negative surgical margins. If margins are positive, the prognosis of the patient is much worse, and that's why we usually try to perform the surgery as radical as possible. In the same moment, however, we know that we may improve the quality of life by reducing the extent of surgery. Of course, with respecting the oncological result. Usually the part of radical cystectomy is in men is the removal of the prostate. So we make cystoprostatectomy in fact. But there appeared already in 80s, 90s several techniques which try to preserve the prostate or the part of the prostate or the capsule of the prostate together with preservation of the urethra and together with orthotopic urinary diversion. On the beginning, these reports were accepted with some skepticism, and there was even some skepticism from the authors itself, because it appeared even in the titles of these papers or in conclusions. But today, based on better imaging modalities, better understanding of the disease, more precise surgical techniques, there are some techniques which may preserve the prostate or the capsule of the prostate, the seminal vesicles or neurovascular bundles, and we know that these techniques in well-selected patients may be an oncologically safe approach which can improve the functional results. From the beginning, there were some concerns about preservation of prostatic tissue, and these concerns are valid even today. There are particularly some oncological concerns. There is the risk of the prostate cancer in the prostatic tissue, and we don't know how reliable we are in detection of the prostate cancer. Also, although we know that the detection of prostate cancer improved in last years. Another risk is the invasion of urothelial carcinoma in the prostate, and again we don't know how reliable we are with its detection before the surgery, and how reliable we are in preventing the recurrence in the prostatic tissue of urothelial carcinoma or prostatic carcinoma. It all may be translated into the risk of local recurrences in reduced long-term survival and so on. And there is another aspect which are functional results. Indeed, we need to really confirm that the functional results after prostate-sparing radical cystectomy are really better comparing to standard approach. Looking on all the data, these are non-selected patients populations which really demonstrated that there is the high risk of invasion of urothelial carcinoma into the prostate in cystoprostatectomy specimen. So apparently we need to be careful. And there is also a significant risk of having prostate cancer or the presence of prostate cancer in cystoprostatectomy specimen. Again, this is unselected, or these are unselected populations. Some of these tumors, even prostate cancers, are significant prostate cancers. So we must be careful, but I must underline these are unselected patients population. What is the reality today? This is the systematic review which was published in 2017 by Virginia Hernandez. They found 12 relevant studies which evaluated some technique of sexual function sparing radical cystectomy in men. They found 3 case series and 6 comparative series with more than 1,000 patients. Of course, the source data are not perfect data. These are not usually not prospective randomized studies, but so we must evaluate it with caution, but on the other hand, these are relevant results. The inclusion criteria in most of these studies were the organ-confined tumors, and no tumor on the level of bladder neck and or prostatic urethra. And if we look on oncological results, we see that the risk of local recurrence was comparable in comparative studies between the standard radical cystectomy and the sexual function sparing radical surgery. The risk of metastatic recurrence was also not higher. And looking on prostate cancer, the incidence of prostate cancer was up to 15%, which is not so bad. And most importantly, there was no ICUP grade equal or higher than 4. So most of them were really not significant prostate cancers. So oncological results looks quite promising. Concerning functional results, the daytime continence was really promising, between 90 to 100%. Nighttime continence, quite interesting data, up to more than 90%. Concerning potency, there were really very nice results for all available techniques or all evaluated techniques without superiority of any one of them. So apparently the preservation of the prostate or capsule of the prostate or seminal vesicles may bring some functional advantage to our patient. This is the technique of vesicle-sparing radical cystectomy, which is interesting because you don't need to preserve the prostatic tissue. It was described by the group around Professor Studer from Bern, and they published recently their results in Journal of Urology. They results from nearly 500 patients with radical cystectomy on orthotopic diversion. In 49 cases, they were able to perform bilateral, and in 75 unilateral seminal vesicle sparing technique. They respected very strict contraindications, which was tumor located at or below the trigone, in a deep invasion into the posterior or lateral bladder wall, or non-organ confined tumor. And they found comparable oncological results irrespective of whether they performed the seminal vesicle sparing or not. But if you look on the functional results, there you can see better daytime continence and very good results with erection after seminal vesicle sparing technique. So this technique is feasible, and in my experience it is quite interesting and not difficult to perform. My personal trick is to use extraperitoneal radical cystectomy, which is oncologically safe in most of our patients, and it may help you to find a very nice approach to the base of seminal vesicles, to neurovascular bundles. So it is a rather feasible approach, and in my experience, really even technically can help you to perform the nerve sparing or seminal vesicle sparing cystectomy. So this is the conclusion of guidelines, and guidelines underline the selection of patients. I think this is very important to stay oncologically safe, so the selection is really crucial. It should be the organ-confined disease and the absence of any kind of tumor on the level of the prostate, prostatic urethra or bladder neck. If you have younger patients interested in his sexual function where you plan orthotopic diversion, this may be a good candidate for some technique of sexual function sparing approach. So don't forget that, but don't forget also about selection criteria. What about ladies? I think in females we use some standard approaches, more or less standard, which are connected with autotopic diversion. So if we decide if the female is good candidate for autotopic diversion, it means that there is no tumor on the bladder neck. In these patients, we usually, if we decide for autotopic diversion, we usually resect the proximal part of the urethra, but we preserve the rest of the urethra, and we try to preserve the neurovascular bundles, because some of us believe that this may improve the continence and voiding and prevent overcontinence or hypercontinence and so on. So this is something that is used in several centers more or less routinely. We also try to, or you should consider the sexual life of your patients, which is connected with vaginal reconstruction, to prevent the significant reduction of the size of vagina, and of course don't forget to preserve at least one ovarium to prevent some hormonal disbalances in the future. So this is something that is the part more or less of routine approach. But what about the prevention of preservation of some sexual organs? I mean, the whole vagina, the uterus, or both ovaries. This is the potentially possible approach. There are some theoretical risks, which is connected with the risk of concomitant gynecological malignancies and consequent local recurrences. But I think that probably this risk is rather low. We should not forget patients with BRCA mutations, because in these patients the salpingo-oophorectomy should be performed after the childbirth in all of these patients. So don't forget this subgroup. On the other hand, there are some potential benefits in preserving these organs, which means it is less extensive surgery, which today is very feasible with robotic approach. Also, in my experience, there is advantage that the vagina and uterus may support the position of the neobladder, which can improve its functional outcomes, reduce the risk of overcontinence. There is no reduction of vaginal size. So this is possible. It again, in selected patients, can have good results. There was published in British Journal of Urology in 2017 this systematic review, which confirms what I said, that in selected patients it may bring comparable oncological and results and improve sexual and functional outcomes comparing to standard radical cystectomy, but the results are very immature. So we will see what the perspectives to this bring. And in the same line is the recommendation of guidelines. So in selected patients it may be the option, but we must wait for further results. So in conclusion, sexual function preservation is possible during radical cystectomy, but important is patient selection and very individual approach. You should remember the oncological results of your patients, because it is the primary goal. But I believe that because of new imaging modalities, less invasive approaches, these sexual function preservation techniques will be more and more attractive in the future. And I am sure it will stay in our armamentarium. So once more, thank you very much for the invitation, and I'm looking forward to your questions.
Okay, Marco, very nice lecture as always. Many greetings from Vienna, from this excellent board. And you have mentioned in your lecture that sometimes you are doing preservation of prostate regarding to improve post-operative sexual function. If you want to exclude prostate cancer, do you recommend to have some multiparametric magnetic resonance investigation or biopsy of prostate, also biopsy of endoscopic biopsy of urethra, and then if you have this result, you can decide it to proceed to preservation of prostate, or you are doing this investigation during surgery. You take biopsy from bladder neck on prostatic urethra. What is your recommendation?
I must say I'm still a little bit old-fashioned. So what I am routinely doing in indicated patients is the preservation of seminal vesicles and nerve-sparing approach, which together with extraperitoneal cystectomy is, to my opinion, quite a good compromise in oncological radicality and preservation of sexual functions. I'm still a little bit careful with the prostatic tissue, I must say, because I saw in my career some patients where the prostate was spared in other institutions by other colleagues, and in some of them I saw really quite high risk of local recurrences. So I must say I'm careful with that. So I don't have personal experience, of course. If I would do that, the technique usually is more or less prostate capsule sparing surgery. And I would, of course, perform MRI and careful prostate cancer diagnosis before including the biopsy. Probably. Another point is the urothelial carcinoma. You, of course, always, when you decide to perform autotopic diversion, you should take the frozen section from the urethra margin, which is crucial to my opinion.
Thank you.
Thank you very much, Marco, for a wonderful lecture on I think a really challenging topic, because as you said, there's not a lot of evidence out there in the literature, but it's quite important to our patients, and it's an area we need to work more on, specifically the sexuality in the woman, which is, you talked about, is still a very challenging area. The first question is, lymphadenectomy that you perform during the surgery. Will you modify your lymphadenectomy if you're going to do sort of a sexual preserving, if you're really looking for, not disturbing their sexual function? Or Studer argues that the presacral nerves should be left in place, so you have the sympathetic plexus and everything still in function. Would you modify that? Because obviously you will do it in earlier stage cancers, and maybe the metastatic rate is a little bit less.
Yeah, if I decide for nerve sparing technique, I usually stay with lymph node dissection lateral to the ureter, not to destroy the nerves which are medially from the ureter. Exactly as Studer described it.
The second question is, in women, organ sparing, is that rate really increasing? Are you more and more in younger women that are, still, the ovaries will live in if they're still premenopausal, but uterus, would you leave it in? And have you ever done, to avoid, that flap of the neobladder in a woman, for example, mesh sacrocolpopexy or something like that? Other techniques that you think may be helpful there?
I think I did in some cases in the past some preservation of the ligamentum teres, and to use that as a support of the neobladder, but I don't think it has a big advantage or it brings any benefit to the patient. So I think, concerning women, it is and preservation of the uterus and vagina, I think this is the question. We were trained that you need to always remove these organs during cystectomy, and I don't think this is true today. We always, it is as any our activity, we should look, we are bringing some limits from the past, but we should sometimes consider whether these limits are really reasonable. And in my view, if you preserve uterus, if it is possible, and is and preserve the whole vagina. It is always advantageous for the lady, even in the age when she is going to have a child or something like that. So it is always helpful, and or maybe helpful if it is safe, of course, and it reduces the extent of surgery. And more or less, if you perform autotopic diversion, then it is probably good for position of the nail bladder. So I think we should rethink what we are doing, and particularly in combination with robotic surgery, it is really very nice surgery when you can remove simply the bladder, preserve these organs, and you can do it very, very, very easily, and I think with very meticulous technique and without blood loss and so on.
Fantastic. A last question, which is a little bit challenging, maybe only a brief answer. The best way of preserving the sexuality is and the functionality is leaving the bladder in. Do you think we will ever reach in the next 5 to 10 years this moment where we can say someone is muscle invasive and we treat it and we don't need to take the bladder out in a significant proportion of our patients, and thereby preserve all this good functionality?
This is a good question. If you ask about significant number of patients, I'm not so sure. I think it should be connected with much more effective systemic treatment and good selection of patients. But in this moment, we probably are able to do it safely in a limited population. Whether this number will increase in the future, I don't know for sure.
Marko, thank you so much for being with us. Thank you for everything you're doing for us and with us. And warm greetings back to Prague. And we will actually meet at many meetings before Christmas and then after Christmas again. Thank you.
Thank you very much, and congratulations for a wonderful meeting. And thank you very much, very, very much for all your effort and activities. Thank you. It was good to see you.
Bye-bye.
So we can continue our meeting. I have last speaker on the list, and Dr. Kilian Gast from Medical University of Vienna. He will be speaking about his topic, which is related to uro-oncology. His topic, and he is concentrated to urothelial cancer, and he was trained by such experts like Professor Houtman and Professor Peter Black from Vancouver. And I would like to kindly ask him to start his lecture, Metastatic Bladder Cancer, State-of-the-Art lecture. Please, the floor is yours.
Dear Chairs, thank you so much for the invitation to give this lecture here during the meeting on metastatic bladder cancer. These are my disclosures. I think we all have observed and seen this dramatic change in the treatment landscape of metastatic bladder cancer. And especially over the last 5 years, we have seen several new compounds, drugs that had a full approval, some accelerated FDA approvals, but also that really changed how we treated patients with metastatic urothelial cancer. But before I come actually to the metastatic setting, I also want to talk about the adjuvant setting, because lately we have an approval for the first immune checkpoint inhibitor in the adjuvant setting. We have seen 3 trials evaluating either pembrolizumab, nivolumab, or atezolizumab in the same setting. While IMvigor010 failed to show a significant improvement in disease-free survival for atezolizumab over an observation-only cohort, for CheckMate 274, that is different. Patients were included when they have either received neoadjuvant chemotherapy and still had presence of muscle-invasive disease or presence of pathological confirmed lymph node metastasis, or patients who did not receive neoadjuvant chemotherapy and were either not eligible or refused to receive adjuvant cisplatin-based chemotherapy, which for years we're using now without really level 1 evidence. When we're looking at the patient cohort, 1 out of 5 patients had upper tract urothelial cancer. 2 out of 5 patients had PD-L1 positive disease, and approximately 40% received neoadjuvant chemotherapy. Those patients were then randomized in a 1-to-1 fashion to either receive nivolumab or a placebo, which was also given every 2 weeks for a maximum of 1 year. The primary endpoint in this trial was disease-free survival in the ITT population and in the PD-L1 positive population. Secondary endpoints were on the side overall survival. And we are looking at the disease-free survival. We do see a tremendous increase in the survival of 21 versus 11 months for the placebo arm. And that seems to be even more pronounced in the PD-L1 positive population. But what about the subgroups of this trial? Does nivolumab work either for upper tract or lower tract disease? I just want to remind you, 20% of the patients had upper tract disease. But when we look at the subgroups, we do see a clear benefit with a hazard ratio of 0.62 in patients who have urinary bladder cancer, but we do not see this versus placebo for patients with upper tract disease. And I still want to remind you that we do have level 1 evidence of the POUT trial, a phase 3 trial that proved that adjuvant platinum-based chemotherapy, either carboplatin or cisplatin-based in upper tract disease, did show an improvement in disease-free survival. But what about the other subgroups? When we're looking at patients with pathological lymph node metastasis, patients who received neoadjuvant chemotherapy, or patients with PD-L1 positive tumors, all those patient groups have a superior disease-free survival over the placebo control arm. But now, coming actually to the topic, first-line chemotherapy. When we're looking at the historic data of platinum-based chemotherapy, we still have these numbers of 14 months for GEM-CIS, approximately 15 months for MVAC, or a little bit lower numbers in median overall survival of roughly 9 months for carboplatin-based regimens. And when we're looking at these historic trials, in an indirect comparison, we do see higher response rates also for cisplatin-based combination chemotherapies. And we know this is not all, and we probably have to definitely to increase the benefits for our patients with first-line chemotherapy. And there are several trials ongoing or have been presented already who tried in combination with IO or IO combinations to improve responses and survival for first-line treatment of metastatic urothelial cancer. But all those trials till now did not show this significant survival benefit. But interestingly, when we're looking at the control arms of chemotherapy, and these were mixed cohorts, patients received either carboplatin or cisplatin-based chemotherapy, we're still ranging between 12 and 14 months. So quite numbers that we know from way earlier before. But when we're digging a little bit deeper in these control arms for current chemotherapy, we do see objective response rates of roughly 50%. And we see here from the Danube trial, which was presented by Thomas Pauls at the ESMO 2020, that actually for response rates, it doesn't seem to matter so much if patients do receive cisplatin-based regimens or carboplatin-based regimens. But what to do actually if a patient is really ineligible for platinum-based chemotherapy upfront? There have been new data from the Keynote 52 trial, which was a non-randomized, single-arm phase 2 trial evaluating pembrolizumab in this setting. And we're looking here at the population response rates. We do see a slight increase in the response rates, up to 47% in patients with PD-L1 positive tumors, compared to patients with PD-L1 negative tumors, where responses were down to roughly 21%. And we're looking at the updated overall survival. We have roughly 11-month overall survival in the median for patients being treated in first line with pembrolizumab. And that seems to be really longer for patients who have PD-L1 positive tumors. But we do see that also patients with PD-L1 negative tumors do respond to first-line checkpoint inhibition with pembrolizumab. And this is something that we've seen and that is still lasting on, and we are waiting for basically this tail of the curve. We do see still this prolonged duration of response in those patients who did respond initially to inhibition of the immune checkpoints. The new topic that came up this year is the maintenance therapy with avelumab. The Javelin Bladder 100 trial included patients who did not progress on first-line chemotherapy. Patients received first-line chemotherapy between 4 to 6 cycles, either cisplatin-based or carboplatin-based, and had either unresectable locally advanced disease or metastatic urothelial cancer. They were then randomized to receive either avelumab and best supportive care or best supportive care alone. And the primary endpoint for this trial was overall survival. And when we're looking at this primary endpoint of overall survival, I think this is such a dramatic improvement from 14 months for the control arm to 21.4 months for the patients treated with avelumab, resulting in a hazard ratio of 0.96 and meaning a reduction in the risk of death of 31%. And when we're looking at the PD-L1 positive patients, we see that this reduction in the risk of death is even higher and greater. We have 44% reduction, a hazard ratio of 0.56, and the median overall survival for patients receiving avelumab and having PD-L1 positive tumors is not even reached yet. But which patients do actually benefit most from this maintenance therapy? We do see that specifically patients with a partial response or unstable disease after platinum-based chemotherapy seem to have a significant improvement in overall survival, while for patients with complete responses after first-line chemotherapy, this difference between an avelumab maintenance therapy and best supportive care doesn't seem to be such big as it is for the other two groups. Looking again in subgroups, patients either if they're younger or older than 65 years do have an improvement. It doesn't matter if patients receive cisplatin or carboplatin-based chemotherapy up front. It seems that patients with non-visceral metastasis have a slight improvement over patients who have visceral metastasis at the presence of the treatment. And again, a slight benefit actually for patients with PD-L1 positive tumors, though it is not regulated in a way that only patients with PD-L1 positive tumors could receive this treatment. When we're looking at subgroups, here the patients that received carboplatin-based chemotherapy and did have a response, meaning a non-progression or unstable disease, we do see a fantastic median overall survival of 24 months. That is something that we haven't seen with carboplatin-based regimens before. We're looking at either how big is the interval between the chemotherapy and the maintenance therapy. It could be from 4 to 10 weeks within the trial. We do see that there's not a dramatic change if you wait up to 10 weeks, though I think there's no reason really to wait any longer and just to go on with an avelumab maintenance therapy if the patient did tolerate the upfront chemotherapy quite well. When we're then looking at the time to the end of the next line therapy in patients with either PD-L1 positive or PD-L1 negative tumors, we do see that the time interval for patients with PD-L1 positive tumors receiving avelumab therapy is prolonged up to 18 months compared to 9 months for best supportive care and compared to 12 months for PD-L1 negative tumors receiving avelumab maintenance therapy. But how about now second-line therapies? Because if we're given checkpoint inhibition already in the upfront setting or maintenance setting, we shouldn't give it in the second-line setting. Updated results from the Keynote 45 trial, which is the only phase 3 randomized trial for immune checkpoint inhibitors that did show a significant overall survival benefit of an immune checkpoint inhibitor, in this case pembrolizumab over second-line chemotherapy, and therefore is the standard of care in the second-line setting. These updated results show an ongoing median overall survival of 10.1 months over 7.2 months for chemotherapy. And again, we see this good response, especially in patients who do respond with a complete or partial response to an immune checkpoint inhibition. We see this ongoing long response that is now over 5 years. And in the second or higher line, we have several novel targeted therapies. There's this big cohort of new compounds which are antibody-drug conjugates, basically kind of a targeted chemotherapy, or real targeting aging, especially FGFR3 targeting agents. EV301 showed a significant survival benefit after platinum-based chemotherapy and checkpoint inhibition over further on chemotherapy. Patients receiving enfortumab vedotin showed an improvement in median overall survival of nearly 13 months versus 9 months. And for FGFR targeting agents, BLC-2001 did show an overall survival of 11 months in this non-randomized phase 2 trial, and we are waiting for the results of the ongoing BLC-3001 trial, the TOR trial, evaluating erdafitinib in the second-line setting. But when we try to summarize this, basically, when we're looking at the perioperative setting, we should check, is our patient eligible for a cisplatin-based chemotherapy? If so, they definitely should receive neoadjuvant cisplatin-based chemotherapy. Other ones won't receive neoadjuvant chemotherapy. After radical cystectomy, now depending on if the patient has received neoadjuvant chemotherapy, then there is still an option of adjuvant checkpoint inhibition with nivolumab. Or patients who did not receive neoadjuvant chemotherapy but are cis-eligible after radical cystectomy, they still have the option of an adjuvant cisplatin-based chemotherapy. Though I think the data for carboplatin-based adjuvant chemotherapy is definitely not so solid that we should recommend that. But what to do now in the recurrent setting after neoadjuvant chemotherapy, after adjuvant chemotherapy? Really depending on the individual patient, that we have an option of a platinum-based chemotherapy if the time to neoadjuvant chemotherapy is more than 1 year, if they did have initial response to platinum-based chemotherapy. Otherwise, in the first-line setting, we still have atezolizumab and pembrolizumab approved. Or you have to move on if patients already received adjuvant nivolumab to further second-line therapies, including vinflunine in Europe, or if you do have access for erdafitinib in patients with FGFR3 alteration, EV or SG. But when we're looking at the metastatic setting quickly and looking at platinum-eligible patients, they definitely should receive cisplatin-based combination chemotherapies. Patients who are cis-ineligible but platin-eligible, those patients should receive gem-carbo in the first-line setting. For both groups, if they do have non-progression on platinum-based chemotherapy, these patients should be offered to avelumab maintenance therapy. Patients who do progress on first-line platinum-based chemotherapy then should move on to a second-line checkpoint inhibition with pembrolizumab. But what to do in the small cohort of roughly 10% of our patient population that are really platinum ineligible? Now the labels have been changed for pembrolizumab and atezolizumab so that we can give now, with the FDA approval, independent of the PD-L1 status, for patients who are ineligible for platinum-based chemotherapy, pembrolizumab, and atezolizumab. So still, after all these clinical trials that we have seen over the last years, platinum-based chemotherapy is still the backbone of our first-line therapy in metastatic urothelial cancer. We still show and see median overall survivals of roughly 15 months for MVAC, but we have to look at these recent trials where actually carboplatin did show a median overall survival of up to 13 months and response rates of 43 months. So in combination, specifically with an avelumab maintenance therapy, there might be even a revival for carboplatin upfront chemotherapy. That is something that we neglected over the last decades for a bit. And only the minority still of patients receive actually second-line therapy for metastatic urothelial cancer, and therefore, although we have these fantastic results for maintenance therapy, there's still room for improvement for the first-line treatment. We have tried to combine GemCis with another chemotherapy. We have tried with targeted agents like bevacizumab. We did fail. We have tried the combination of upfront chemotherapy with immune checkpoint inhibition. We did not see the improvement in progression-free survival that we were hoping for. But when we're looking now at estimates of survival, and we're still lacking really real-life data in these new sequences, but we do see estimates of roughly more than 2 years for patients who did respond on the first-line chemotherapy and then received an available maintenance therapy for those patients, while all other sequences, second-line checkpoint inhibition, does seem to have lower median overall survivals compared to those patients who do initially respond to a platinum-based first-line therapy. So therefore, I want to come to my conclusion. Definitely, although we have fantastic data for adjuvant treatments now with checkpoint inhibition with nivolumab being approved recently, we still should offer neoadjuvant cisplatin-based chemotherapy to all of the patients whenever it is possible. We should offer nivolumab in the adjuvant setting in patients who did receive platinum-based neoadjuvant chemotherapy, who are ineligible for cisplatin-based adjuvant chemotherapy, or those patients who refuse adjuvant chemotherapy. In the first-line setting we're still talking about platinum-based chemotherapy. Whenever it's possible and indicated, you should give it. You should offer avelumab to all patients who do not progress on the first-line platinum-based chemotherapy. First-line checkpoint inhibition should be only used in those patients who are really platinum ineligible. Second-line checkpoint inhibition, like I said before, Keynote 45, the only phase 3 trial with level 1 evidence for pembrolizumab in this setting. But you have to be careful if a patient actually did receive avelumab maintenance therapy already. You really should think that progression under maintenance therapy with avelumab probably doesn't result in a response of another checkpoint inhibition. So therefore, we have several novel targeted therapies, including erdafitinib, enfortumab, or SG, and hopefully those will really again improve the survival of all patients that we are treating every single day in our clinical practice with metastatic urothelial cancer. Thank you very much.
Thank you very much, Kilian, for this wonderful talk on a very rapidly evolving field and also rapidly evolving concepts. So let me get at what the first point of your conclusion. I think it's a very important point. Is a change in our concept and understanding of the role of carboplatin in our armamentarium, which was like the ugly animal we never cared about, we tried to avoid, and we saw as a failure, as a palliative concept, and now it's changing role. So in the EAU guideline, and similar to your conclusion, ideal, let's say in cisplatin ineligible first line, do I understand correctly, you would preferentially go for carboplatin combination, even if they are PD-L1 positive, not only in the PD-L1 negative. Is that something that you're trying to enforce more?
I mean, I think really with the data that we do have, and we're still lacking often in direct comparison, but we do see quite good responses for carboplatin first-line therapy. And I think especially if patient has a high tumor burden, if they have visceral metastasis, they definitely do need an aggressive treatment, and therefore carboplatin is definitely better than a checkpoint inhibitor. Those patients, I would say, some lymph node metastasis where I do know they have a PD-L1 positive tumor, I mean, I probably still on a single patient base, I would still go for a checkpoint inhibitor, because if he does respond, he has this tremendous good response over a long time, and I might still spare him to undergo chemotherapy. So I think this could be really on an individual patient base that might have a benefit. But in general, I think from the data that we're looking at, yes, we do have to recommend carboplatin-based regimens if a patient is cis-ineligible but platinum eligible.
Okay. And the other question, I mean, some patients come to us, and you have the same thing, in our practice, and they say, look, if I can get a targeted therapy, because we promised them precision medicine will advance the field, and here we have a targeted therapy with FGFR targeting agents, for example, and we're still leaving that behind and first have them run through things. So how do you explain that to your patients, and how do you feel about that in general? Do you think it's just a matter of having the trials in the first line, or even further in the adjuvant or neoadjuvant setting?
I mean, I think the field will definitely change, and I do see those highly specific targeting agents really coming in the frontline therapies. But I think till now, we're still lacking really the data. And although we do have FDA approvals for erdafitinib, for EV, real life in Europe is you are happy if you get this patient into an early access program or anything, because they are still not approved by the EMA. So therefore, I think at the moment we have to stick with what we have. If you do have access, definitely you have to stick within the approval anyway. So therefore, upfront chemotherapy, if you can give it, and then go on. But I think especially now when we're looking at the first-line setting, combination of checkpoint inhibition with EV, and we have seen fantastic response rates even in heavily pre-treated patients, I think there's no-brainer that if you have that efficacy and a targeted chemotherapy that has less side effects than our systemic, uncontrolled chemotherapy, I think if we do have the data for it, we will see it really in the near future in the frontline setting.
My last question. If you look at the previous talks, you look at prostate cancer, you're talking not about doublets, we talk about triplets on the first line, that's the future, and maybe quadruplets. In kidney cancer, we're moving already doublets. In bladder cancer, sort of the combination at the same time did not work. HIV, a model of a successful disease we treated, and we keep into chronic disease, it's multi-targeted therapy. So you already talked about EV and pembrolizumab yielding like incredible results. Chemotherapy with checkpoint has not really brought us the miles we brought. Where do you think the field's going to go into the future in here?
I mean, to be honest with you, I think that question still hasn't been answered, and I'm still unsure if not the combination of chemotherapy and the checkpoint inhibitor wouldn't the way be to go. But I think the trials that we did run to answer that question were not ideally designed. So we tried early combinations up front to get the data out. But I think we really need, in this disease that is so inhomogeneous, where we have so many different subgroups of patients, we definitely have to see basically if in selected patient populations we do find the ideal combination, and therefore I think we have to design smarter trials with better selected patients to actually be able to answer the questions if there are subgroups that might benefit from upfront combination therapy.
Thank you very much, Kilian. This has been wonderful. Thank you very much for enlightening us on this field and moving target. Everybody knows that bladder cancer is my passion, so I'm always interested to hear everything that is happening moving forward. Thank you for being with us and sharing all this with us. Dear listeners, dear colleagues in Europe and beyond, whoever is listening and who's going to follow us, Thank you for being with us this afternoon. We absolutely wanted in these rather difficult times still to give you cognitive information, tips and tricks, surgical, oncology and non-oncology, really advance your understanding and share with you some of the important speakers and their knowledge in the field of urology. We thank you for spending the afternoon with us. Again, I want to thank our supporters, without whom this would have not been possible, that they have given us grants to make this event possible. Our platinum partner, Astellas, who has been a great supporter for really a long time. Gold partner, Janssen Oncology, fantastic supporter as well for a long time. And bronze partner, Richard Wolf, BMS, and our copper partner, BK Medical, and Medtronic. Thank you for your support for this event. I want to thank the speakers. I want to thank my two co-chairs, and I want to make you aware that the Central European Urologic Society is a society that is young, with a pounding heart, that really wants to go miles and kilometers as far as it can with you, for you. And the society belongs to all Central European urologists who want to participate and work with us to creating a better future for our urologic patients and urologic science and knowledge in general. Our in-person meeting that we will have will be in April 2022. Please check out the website. It's called Central European Meeting Urology. You can just put it in Google, you will find it, and we have a meeting in person where we're going to have hands-on courses, we're going to have live surgery and other events and lectures as always, but at least this will allow us to meet in person and really mingle and spend time together. Thank you very much. Ivan.
Thank you very much for the invitation to this meeting, Sharok. And I would like to congratulate you and your team, and Peter also, that you have prepared such fantastic and very high-level scientific meeting. I have very nice impression from this afternoon and all day, and I am looking forward for the next meeting, as you said, next year in April. Thank you again.
Dear colleagues and friends, dear President, please accept the best gratitude for the highest level of this meeting, construct the perfect program and the quality of this meeting. The previous one, this one, and the future clearly emphasize that it was and you should be with us. Thank you very much. All the best.
Thank you very much. Goodbye. Good night.